Thank you very much for the opportunity.
All right. It is an absolute honor and privilege to introduce the next speaker. It's Mandy Token. She's our Netcare Group Trauma, Transplants and CSI Manager, and she manages everything in Netcare. She's an absolute privilege to have her on, and it's also, she has got extensive privilege in major incident, and she's definitely my mentor and manager, and I just want to make this opportunity to say Happy Bosses Day, Mandy. Thank you for giving up your Saturday, and I'm very excited to hear what you have to say to us. And she's going to present trauma systems for us. Thank you, Mandy.
Thank you, Marisa. Can you hear me?
Yes, Mandy, we can hear you.
Can you see my screen?
I can.
Okay. To all of you out there, a wonderful Saturday, probably the hottest day of the year. And thank you for joining us in this very valuable symposium that Marisa has put together. I think I've just lost my screen. Is that correct?
We can see it, Mandy.
Can you still see it? Okay.
Yes.
So I really want to talk to you about trauma systems and you can stop me at any time that you can't see my screen, trauma systems and trauma programs. Because you can't run a trauma system without a trauma program. And funnily enough, running trauma systems in KZN and in the Cape are relatively new concepts. In Johannesburg and Gauteng, the understanding of a trauma system has been quite widely accepted and implemented, but unfortunately, it's taken us a long time to get KZN and to get Cape Town on board in terms of understanding what a trauma system is and how a trauma program actually works. And it is unfortunate that that we still have systems or hospitals that take polytrauma patients or patients with injury severity scores of above 15 into their systems and then tell families they did the best that they can do. So you can't run a trauma system without a trauma program. And I think it's very important that we go through both aspects of the trauma system versus trauma program. So you should be seeing my new slide, which says, do we need a trauma system? Is that correct, Marisa?
Correct, Mandy, we can see it.
Okay, so this very interesting slide here is a slide of a vehicle being really basically pulverized by a truck. And the question I ask is, do we actually need a trauma system? And I think the answer for everyone is yes, otherwise you wouldn't be on this talk today. Or perhaps you're on this talk because you need to understand more how to set up a trauma system or how to run it. Now, even in Netcare, where we've been implementing trauma system principles since 2014, 2013 or 20, even before that, in 1993 was the first time I did a presentation which had a little man looking up into the sky with his goggles and saying, I have a vision. And then there in the top there was a spaceship which said a Netcare trauma system. So my answer to this is definitely, we're one of the countries with the highest trauma cases per year with facilities that with fatalities. And in fact, one of the current trauma systems or one of the current hospitals within my own trauma system have a mortality rate of over 40% from trauma cases, and we're quite concerned, and that you can only find out if you're actually monitoring and you actually know what you're doing. So we have 1 million cases per year, trauma facilities. Of those, 1.5 million present at non-trauma facilities, and that's quite sad. That number should be completely turned around. There should be 1.5 million presenting, or there should be 2.5 million patients with injury severity scores above 15 presenting at trauma hospitals with accredited trauma systems. You know that violence is more than half trauma load in South Africa. Now it's probably more than 70% now, and homicide, suicide, and transportation accidents add substantially to the trauma burden of disease in South Africa. And you know that if you look at South Africa's injury profile, it's completely different to the rest of the world. This is our injury profile: homicide, suicide, and transportation accidents. Trauma in South Africa targets the young and productive in society and imposes a major burden on our healthcare infrastructure and our finances in terms of actually being able to recover people who've been involved in trauma. So if we look at trauma system accreditation through the Trauma Society of South Africa, there's been a lot of criticism of the Trauma Society there's been a lot of criticism about systems that get accredited by the Trauma Society, saying that they're not really the official accreditors. They are, as any other country in the world, the people who know most about trauma. You've got trauma surgeons involved, you've got trauma managers involved and trauma nursing staff, and they definitely know exactly what they're doing when they accredit you. And if you do get an accreditation, you can then proudly say that you've met the criteria for either a level 1, 2, 3, or 4. And it doesn't matter what criteria you meet, because it starts as an endpoint where you can now work yourself up to the next level. However, not everyone is supposed to be a level 1. And this is what people don't understand. You need one level 1 for about 10 million or 15 million population. So to have 2 level 1 trauma centers in one town is actually poor understanding of trauma systems. You should have one level 1, and then you should have level 2s, level 3s, and level 4s. So Netcare, Mill Park, Union, and St. Anne's Hospital are the first to be formally accredited as level 1 trauma centers in South Africa. There are other hospitals which have been accredited as level 1, and there are many hospitals which claim to be P1 or level 1, which confuses the public out there. So P1 hospital to me says you're a priority 1 hospital of what? So you need to understand, if you are going to call yourself a P1 hospital or a level 1 trauma center, that legally in court you should be able to defend the fact that you've met the criteria by the accrediting body for being a level 1. Other level 1s have been instituted, or level 2s and level 3s, and that's why you must understand that Netcare does not have more than 3 level 1s at this stage, and hopefully in the very, very, very near future, a 4th level 1 in the Cape region. Very difficult to get people to change their minds about where they refer their trauma cases based on the fact that somebody has achieved an accreditation. We're still very sensitive about supplying systems with priority 1 trauma patients that actually can't care or don't have the adequate processes in place to manage those patients. So let's have a look at the level 1s. You can see that it's Netcare Mill Park, Netcare Union, and Netcare St. Anne's Hospital. And then you've got level 2 units, and then you've got level 3 units. So I can say there has been significant improvements in both processes of care as well as patient outcomes since Netcare commenced the Trauma Society accreditation. We pride ourselves in the improvement in patient outcomes. This has involved an enormous amount of work and hard work and dedication from all working in emergency and trauma care. And you can see the following units have been accredited. And then if you look at the next one, you can see that these are level 3 trauma units. We will never allow these units to progress to level 1, or we may allow them to progress to level 2 because the care is more organized in a level 2. But currently we are comfortable with the Trauma Society of giving us the level of care that they currently have, and we're quite aware of what work needs to be done to improve these units within our trauma system. So let's see the difference between trauma programs and trauma systems. And I've got to thank Renee Robles for these slides, because the majority of these slides were done by her, and a very good understanding. She's the one of the senior members in my team. So trauma program is a multidisciplinary approach to trauma care. It extends from the time of injury, in which Gary was talking about managing the patient on the scene, sending an ambulance, getting there quite rapidly, ensuring appropriate care is given, and then to discharge from trauma care and even into rehabilitation. And it occurs within a hospital and its immediate area of influence. So a multidisciplinary approach to trauma care is what is known as a trauma program. If you look at a trauma system, it encompasses all aspects of trauma, from prevention strategies to post-rehabilitation. And if you look at the activities within the Netcare trauma system, we have injury prevention programs, which we call our Netcare TIP, Trauma Injury Prevention Program, where we do lots of work at schools and at events for children, like wearing their helmet properly, not touching dogs, how to approach dogs for rabies. We do lots of other stuff about distracted distracted parenting, cell phones in cars, all this kind of stuff is injury prevention. And people say, isn't that sort of counterproductive because you're stopping trauma, which means that you won't get as many trauma cases? Well, if that's the reason you're in business, to get trauma cases, then it's quite sad. What we are doing is ensuring that we're involving ourselves in the community to ensure that we don't see these horrific injuries like farm injuries, gate injuries, animal snake bite, people in the Kruger Park playing with the lions by getting out their car and taking pictures. These kind of things are all involved in our trauma injury prevention, including, and very proudly, a blood conservation program and collection of blood units. So we can say that if we use blood in our trauma system, it is our responsibility to return blood to the trauma system. And so far, the trauma system within Netcare has returned probably over 12,000 units of blood to blood bank by running blood conservation, first of all, and ensuring we don't inappropriately use blood and order more blood than we should. But second of all, having blood donation projects at our hospitals and ensuring that blood bank gets blood back into the system. So the goal of trauma system is to decrease the risk and burden of injury and to individuals, to the society, and especially to South Africa. So this is really how trauma programs and systems work together. The larger wheel is the trauma system, and within it is the trauma program. And you can see that the level 1 sits at the center of the entire trauma system, and level 2 units feed. Sorry, guys, just give my dogs 2 seconds to realize they're going for a walk. Thank you. And the level 2s feeding into the level 1s, and the level 3s feeding back into the level 2s or the level 3s. And in most instances, you should actually bypass a level 2 unit if you have a trauma in a level 3 system and go straight to the level 1. And I really apologize for all my rescues getting so excited because they're going for a walk. So the benefits of a trauma system and program is that you get a 15 to 20% increase in survival rates of seriously injured patients. The important thing is, if you are a trauma system and you are running a trauma program, is that you must be able to prove that. There is no way that you can tell people that you're a level 1 trauma center if you're not able to prove that your patients that come to your system have better survival. And I'll show you that just now at the end of this presentation, where we can absolutely prove by doing a research and an artificial intelligence research of our patients that have been entered in our Medibank trauma system, where we're able to show that our patients actually do better coming to a level 1 trauma center versus our patients going to our level 2s, 3s, and 4s within our own system. So the time between sustaining the injury and receiving definitive care is an important predictor. And so you don't look at long-term patients that are coming out of country and have spent 5, 6, or even 7 days before they're referred to you fraught. So you get a guy that's bitten by a crocodile, he goes to a local hospital where the plastic surgeon tries to manage him on his own, or the orthopedic surgeon manages the crocodile bite. And then 5 days later, he gets transferred to a level 1 center because they realize that they're not doing very well. And then you have to have a significant higher mortality on these kind of patients because they haven't arrived early, where people understand how to manage crocodile bites, and where people can, and where the surgeons and the right antibiotic and the social care of the families and real person-centered health and care is carried out. And in the end, you get someone leaving your system with 4 limbs or 2 limbs amputated, where that patient probably would have had a survival going forward. And you also then reduce your preventable deaths, which is quite interesting, and I'll show you that data later as well. So you've all heard this, the right patient to the right hospital to the right at the right time. Okay, and this improves trauma outcomes. Now, this is a difficult concept for us in South Africa, because if you have a red ambulance, then you must take your patients to red hospitals, where they are capable of managing. If you have a green ambulance, you must take your patient to green hospitals. And if you have a blue ambulance, you've got to take your patients to blue hospitals. And that is very unfortunate, because in the end, it doesn't matter whether you're the red, the green, or the blue hospital. In the end, what matters is, are you able to prove that your outcomes are better? And are you able to, through accreditation, to prove that you've been able to care for these patients and do the best for the patients to ensure the most appropriate outcome? Now, if you look at the probability of survival, I don't think there are many units in the country that actually plot their probability of survival using the TRIS, or the Trauma and Injury Severity Score, to calculate anticipated deaths that survived. Okay, so if we look at these anticipated deaths for 2021, in Netcare Level 1 trauma centers, so this will be Netcare St. Anne's, Netcare Mill Park, and Netcare Union Hospital, we can see that above the ISO 50 bar over here, patients above the bar are anticipated to die because they have an injury severity score of 75. And you can actually see that there's a patient here that survived, that's got an injury severity score of 67, but most patients with injury severity scores above 75 die because they're expected to die. What is interesting here, okay, is these blue dots above the system. And that is patients that have anticipated to die but have actually survived. And also, what needs to be looked at in a morbidity and mortality study is, why do patients with relatively low injury severity scores die who should have survived? And the problem here is, these are the burns patients. Remember how the TRIS works, and these are the single system severe gunshot head injury, pelvic injury, or burns. As long as these are discussed in an M&M, and as long as these are discussed in an M&M, and that you are then looking at whether that was an anticipated survival or something went wrong, and you can close the loop, you're actually doing your patients quite a disservice. So the success of a trauma system is thus then, okay, largely determined by the degree to which it is supported. And that's got nothing to do with the success of the hospital seeing patients, but it has got to do with the success of patients surviving their trauma. Okay, if you support the level 1 system and you stop getting hysterical about passing other hospitals to go to the place where the patient is best served by a system and best cared for by a team within a system, by a program who's doing research, then you are doing the best for your patient. However, if you're still territorial and you still believe that you have to defend the fact that you have driven past a hospital to take the patient to the best area of care, then you need to really have some serious talks about how you are doing a disservice to the people that you're treating. So don't rush to these calls with lights and siren and go and treat these patients and then take them to an inappropriate hospital. You might as well drive slowly, and then they can die on scene, and then nobody is being accused of not doing proper trauma care. And so if you are a paramedic or a nursing sister or a doctor with ethics, okay, who knows that patients best survive at hospitals that are able to provide best trauma care, whether that be within the Netcare program or within any other program in the country, then patients should be taken to those systems to be cared for, and not necessarily taken to the hospital that gives you the best pies, chips, and Coke. So Trauma Society of South Africa, I've been involved in it since I was 12 years old. I lie. I've been involved for many years in the Trauma Society of South Africa, and I believed in the accreditation and was involved in the inaugural setting up of Trauma Society Accreditation Criteria as using the American Trauma Society of South Africa, the American Trauma Society, to look at how we could adapt. I worked with Professor Boffard and Professor Goosen and many others within the Trauma Society to look at how we could change trauma, the accreditation into the South African context, and many years ago, and we started looking at how we could improve care. And you must take the Trauma Society accreditation document and use it as an audit. and use it as an honest audit. Do you have this? No. Do you have this? No. Do you have this? Yes, 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 and yes. And you can see where you are. And it also gives you quite a nice audit document to look at how best you can reach either that one level 1 trauma center in your total system, or whether you are actually a trauma at a level 2, or maybe you're a very good level 3 that can become a level 2 just by getting a capnograph and putting a capnograph in your emergency department, or having a paging system, or looking at the outcomes, or looking at your blood usage, all that kind of stuff. Okay, so I think you all know this. There's a document published which says a level 1 trauma center is able to provide leadership and total aspect and injury of care. So ultimately, a patient seen in a level 1 trauma system should not need transfer out. So if you're a pregnant mother arriving at a level 1 trauma center, you go into labor, your baby is delivered while they are managing your spleen, your liver, and your ankle injury, and your baby is transferred to the best center for that baby, or kept within your system if you're able to provide trauma care. And I explained this as Mill Park. You get a mother who's a gunshot abdomen. We deliver her baby urgently. We transfer her baby to another hospital that's able to provide care for a baby. We don't try and manage the baby within our system where we have no expertise in managing premature neonates of gunshot mothers. And in the end, mom is better, baby grows and survives, and you can send both home to become productive mothers, become productive members of society. You look at trauma in a level 2 center, they are providing initial definitive care regardless of the severity of injury. However, due to the nature of their resources, they may not be able to provide the same comprehensive care. And in fact, there is no shame in transferring a patient from a level 2 trauma center to a level 1 trauma center where they can deal with their injuries. Or if you have a trauma surgeon in a level 2 center, but you have not been able to get level 1 accreditation, then you can manage your trauma case as long as you're having your M&Ms and looking at the care that you provide. There's level 3 centers, and I don't really want to go through it because you can go and look this up yourself. And there are level 4 systems, really provides basic trauma life support, and then the patient has to be transferred for definitive care. And it's usually situated in a clinic, not a hospital, and it may or may not have a doctor available on site. So your paramedics, in fact, may be able to provide better trauma care than actually taking a severely injured patient to a level 4 system where there may or may not be a doctor available. So I've got many slides here of the accreditation criteria, and you can see E stands for essential, D is desired, and you can see that most of the level 3 and level 4 requirements are desired. However, some of the level 2 requirements are either desired or essential. And level 1 is essential in all the criteria. And I'm really not going to go through every single page. They are freely available from the Trauma Society of South Africa, and there was also an article published on trauma accreditation, and you can go and have a look at that. And you can just see that it deals with emergency medicine, it deals with trauma, and deals with cardiology and stroke. You can't be a level 1 trauma system if you're not able to provide stroke care at the same level as trauma care, and cardiac care at the same level as trauma care, and pediatric care at the same level as trauma care. But you might have to transfer your pediatric patient because you can't admit pediatrics at your hospital. And we do have some level 1 trauma centers that are able to care for that pediatric patient, but can't admit them. So we prefer that those patients then go to dedicated pediatric trauma systems. And you need heads of department and maxillofacials, and there's lots of doctors that you need, and ACLS, ATLS trained people. And so you can move on, and I'm just going to move on. I hope it is not driving you insane, but I'd like to really get to the end. In some presentations, I have to present all these levels to the people. So let me just go through it. And you can see here, if we stop here with Gary on the appropriate equipment to resusc patients of all ages. What's interesting, and something that I need to tell you from previous when I was involved in trauma and I was still a baby within the trauma system, when Garden City was the only trauma unit in the country, it was quite interesting to note that the only reason you could become an emergency department is if you had a resuscitation service on the same floor as X-ray, and you had a laryngoscope blade and handle, you didn't need ET tubes, and you had a bag valve resuscitator. That was the criteria for you to become, oh, you needed a McGill's. That was the criteria for you to become an emergency department. Things have changed significantly since we have moved on, and you heard that from Gary in his presentation. I'm sorry about this. I'll just quickly move through this. I'm happy to supply this presentation, and will also be on the intranet and available to all of you. So let's just have a look at this slide now, which is anticipated trauma deaths but survived within the accreditation or within the trauma system. And these are one of the statistics that you need to look at. And you can see that we look at Mill Park, Union, and St. Anne's on a quarterly basis, and we look at how many of their patients were anticipated to die within that, above that line on the ISO 50 bar, but actually survived. And these are the kind of things you need to look at to understand whether you're actually making a difference to trauma care in the country. And if you look at level 1 trauma mortality measured against the international benchmark, which is 4%, we can see that within our hospitals, Mill Park, Union, and St. Anne's, we have a 5.73, a 4.46 in Q2, a 6.4, Q4 an 8.83, and total 6.36. So we still haven't measured, we still have a lot of work to do to measure ourselves against international benchmark. And I'm not embarrassed to show this. It's important that you actually know your statistics and what work needs to be done. So a trauma systems approach is used to improve survivals for P1 trauma patients with an injury severity score of above 15, ensuring that these cases, especially if these cases are taken directly to a level trauma 1 center and are not played with. And the target is 28%, okay, of P1 patients. And you can see that in most instances for our hospitals in Mill Park, Union, and St. Anne's, we are reaching the 28% with an average for the year of 30% of our patients with an injury severity score of above 15 are taken to level 1 trauma centers. If you look at the components of a trauma program as well, you need to know that a trauma program includes research. It should have injury prevention. It should have the data registry. And we have a significant data registry of over probably 5 to 6 million trauma cases already inputted into the system. You need to be involved with EMS. You must have an emergency department. You must have a theater that's dedicated. You've got to have an ICU that's dedicated to trauma care. And you've got to have a rehabilitation system that you work with. And all of this provides the components of a trauma program within a trauma system. So the what, the areas, and you can also see that if we talk about research, this is only the research for this year. So we have a trauma outcome study that's been submitted, a gait injury study that's got ethics and research approval. We have animal-related injury scene. So there's quite a lot of research going on. Okay, so there is evidence, okay, to state that patients, the implementation of a trauma system in Orange County, California, had significant impact on the quality of trauma care. And I've said this about the Netcare system as well. The proportion of deaths judged to be potentially preventable dropped significantly, and it was associated with significant increase in patient age and severity of injury for those patients dying of vehicle traumas. That was in 1984. We've been very slow to move in most of our emergency departments. I know that patients in many units experience only a momentary pause in the act of death because they're going to the wrong systems. Poor resuscitation leads to a triad of hypothermia, acidosis, and coagulopathy. And most of our trauma patients that are poorly resuscitated die of multi-organ failure or blood loss when you're unable to stem the flow of blood because you're CT scanning them to death in the donut of death. The injury severity to death ratio is constantly being driven upwards in trauma centers with trauma systems. And the big picture of trauma resuscitation is very poorly understanding. And I did a presentation, very poorly understood. There was great English. And I did a presentation a while ago, which calls Before Times Are Critical. And I think that we're at a stage in our country in South Africa where trauma care needs to take a significant jump into the real world before times in your hospital become critical and before our patients don't survive. I hope you are still with me and there are no issues, Marisa, on the presentation. The final bit, Marisa, is everything still all right?
Everything's fine. Thank you, Mandy.
So the final bit of my presentation, I hope you're not bored with me, is to show you that research is very important to see whether your trauma system is actually making a difference or not. And we joined up with a company called Choice and Emerge, and we looked at a research program called Leveraging Behavioral Economics and Artificial Intelligence to see whether patients who come to level 1 trauma units actually have an increased chance of survival. And we took the Medibank data where we put all our P1 patients into Medibank, and we were able to use machine learning or artificial intelligence within the system. So artificial intelligence in healthcare, it's being used to improve wellness, detection, admin, and diagnosis, amongst many other things. And so you can actually tell the computer what you want it to learn, and then it starts putting the data in, and it learns significantly, and it starts pulling out the data. So 90% of global deaths occur from trauma in low and middle income countries, and the incidence of trauma injuries in South Africa is notably higher. We have 50,000 trauma-related deaths a year. And we only, when we did the study, St. Anne's was not an accredited level 1. So we only looked at Milpark and Union, which were the only 2 accredited level 1 trauma systems within the system in South Africa. And so we extracted emergency department data from Medibank for a 5-year period, and we extracted mortality and survival data of P1 patients entering the ED, including demographic data, injury severity, deaths in the ED, and deaths post-ED. And so initially we had a total number of 138 variables relating to 34,832 emergency department admissions. And the computer took those 138 variables and learned what needed to be done, and then decreased those variables significantly. I don't know why my screen's not moving. I just want to get out of the presentation because my screen is not moving, and I'll just share again. Is it sharing now again?
Yes, Mandy.
Okay, let's see if it'll move. Okay, now it's moving on. So basically, we looked at a stepwise forward multivariate linear regression system where we took those 138 variables, and any variable that did not attain a statistical significance of 5% was excluded from the model, and we moved on and then correlated. And we looked at various things. We looked at what trauma unit, is it Milpark or Union, the time between incident and arrival, time between blood called and results, Medibank patients. We looked at the TRIS, and we looked at TRIS scores, ISS, new ISS, level of stability, and you can also, we had a look at medical aid, and we looked at other data. And roughly 1.01% of our P1 trauma patients died on admission. And then for Milpark, Union, St. Anne's, Christian Barnard, we had a reduction in total mortality for P1 trauma cases, as you can see. So for Milpark and Union, we had a 76% reduction in trauma cases, all things being equal when we looked at the system. So if you look at the results, you can see that the reduction in total mortality for P1 trauma, and you looked at everything being equal, was 60% at Union and 90% at Milpark, which also shows the different type of patients and perhaps a different approach to resuscitation. But in any case, if you look at the reduction in total mortalities of P1 trauma between 60 and 90%, my, are you looking at good results here? So we were able to then say, we could successfully prove the hypothesis that trauma increased the probability of survival, okay, that our trauma care, that there is validity in overflying hospitals, that we can justify major trauma in Netcare going to trauma centers, that the medical aids will buy into the system because we now have the data to prove that overflying other hospitals gives its members and its patients a higher chance of survival. We also proved that there's value in having a database such as Medibank, and that Milpark is leading best practice in trauma care in South Africa. So there was quite a lot we were able to prove. So if you look at this with our 911 teams underground, providing care urgently to a mining injury or someone who's collapsed in a mining situation, he shouldn't be taken to the closest hospital in the Vol Triangle just because it is the closest. He should probably look at bypassing all other systems to get to a system where P1 trauma care can be provided. Thank you very much, Marisa.
Thank you very much, Mandy, for an excellent presentation. Is there any questions to Mandy?
I hope I've been on time, Marisa.
Spot on, Mandy, spot on. Thank you.
Is everybody going to let me get off scot-free and give me no questions? Okay.
Okay, thank you. Just give me. I just want to put the next slide on. Just give me one moment.
Thanks, Mandy.
Just want to share my screen. Please let me know when it's up. Can everyone see it?
You can see your screen, but you must go into presentation mode, Marisa.
Now, Mandy. Okay, I just want to introduce Professor Clark, our trauma director at Netcare St. Anne's Hospital. He's obviously a specialized trauma surgeon. He's also head of clinical unit at Grace Hospital. And I just want to say that Prof. Clark has basically published peer-reviewed publications, 266 of them. So he's an absolute research orphan. Prof, thank you for doing this for me. I just want to get this sorted. And then we should go. Just have a seat.
Okay, right. Well, I didn't ask any questions there, Mandy, because it was a very good talk. And so many of the things that you said, the sort of broad picture, I'm now going to try and tease out in this individual case. And I think this case, the outcome is not complete success in the end, but the patient is alive. And it also reflects all the things you've been saying about trauma systems. Okay. Right, so complex trauma. We're not talking about people who've sprained their ankle, who've chipped a nail, what Prof. Robles used to call a champagne glass injury. We're talking about complex trauma. And there's multiple injuries. We need to prioritize what we're going to do. We need to be pragmatic, right? So there's guiding principles. We need to be pragmatic. We need to be open to information coming at us from different aspects. We need to have a sense of balance, and we need to have some clinical judgment. So this lady, right, I've spoken to her and she's still in hospital. She's very happy to use this details for a talk. It's a 48-year-old lady who was a motorcyclist on her Sunday run in Durban. So I'll say that in Durban because we're in Maritzburg. So she was brought from Durban to Maritzburg, knocked down by a speeding car. And I think her husband, I don't know if they're on the same bike or if he was also injured. He was taken to our level 2 center in Durban. He also did well, but she had a blood pressure of 80/40. So as soon as you see that, you know, well, this is a significant injury. You know, the mechanism is significant. She's been knocked off her motorbike, high speed, car sped off. She's hypotensive. 80/40 is shocked in anybody's definition. And her left foot is sort of half ripped off, partially amputated left foot. And the right knee is badly angulated. So that's her scenario. So now the paramedics are there. They're on the side of the road. They have this, you know, we've heard from Gary this morning. So she could have a spinal injury. So they have to treat her with some kind of spinal immobilization. All right. Obviously, there's a bleeding issue that the leg is half ripped off. So they need to put up some sort of line. They need to get a line up. just to complicate things, she's got a dislocated knee on the right, a half amputated leg on the left. She also managed to break her left arm, so there's not much place to put in lines. It's on the side. I mean, the weather wasn't bad. I suppose a bit hot, nice, sunny Durban day, but still you're trying to put in lines with, so I think they did put in one of these interosseous lines in this patient. The leg, so now we've got this leg that's basically half amputated. So we know now that that's a source of bleeding. So the issue is, should we put in a tourniquet? All right, so it's just something to think about. We've learned now from the military experience, traumatic amputations, you don't want the patient bleeding to death. The paramedics didn't put on a tourniquet. It was a reasonable decision. They put the leg in a sort of splint. They put a bandage over it, and the patient was airlifted. Now, I think what I will say about this airlifting, Marius and I did go through the time frame. I think the patient's accident was 10:30, or the call came by 11:15. The chopper was there at the side of the road, and certainly by 1 o'clock, the patient was in St. Anne's Hospital, and by quarter to 4, was it? She was in theatre. So that's less than 6 hours. And I think you can definitely say that this HEM system helped this lady. So when she had responded a bit. She was fully conscious. Tummy seemed to be soft. She was screaming in pain. Those were what we saw. Left arm swollen, left foot. There's the left foot. All right. So now this is also interesting. So the paramedic said to me, "Doc, there's no pulse there." So what did I think? I thought, well, come on, man, I'm the head of trauma here. There's no pulse because the leg's half ripped off. Anyway, but you must always stay open to what people are telling you, right? Because he said there's no pulse. Anyway. So you can see it's quite a badly mangled limb. There's dirt in that looks like a bit of pot scour there, that muscle. There's a bit of leaf in that bone, the bone sticking out. There's the x-ray. It's a compound leg. So that's obviously very right. And that's what the findings were on that side. So my assumption was, okay, well, the reason there's no pulse is because that foot is almost off. Right, so then we sort of have to sort of look at a few things. I mean, this is when I use this to teach the medical students. I ask them about mangled limb scores, blood supply of the foot. How do we manage complex wounds like that? That needs to go to theatre. It needs to be washed. The blood supply of the foot, we know there's a popliteal artery, which is higher up, and that trifurcates into 3 vessels. So really, by the time you're at the foot, there are 3 vessels going down. And obviously, this is a mangled limb. So mangled limb score, according to the mangled limb score, it's quite a severe mangled limb. So she wasn't over 50, but she was certainly not 28. That leg was ischemic. She had been shocked, and she had quite a disruptive injury. So now, of course, the trick is that you've got all this stuff coming at you, and there's multiple injuries in this patient. So here's her right knee, okay? Now, she was screaming in pain, obviously, and that's a dislocated knee. So what's the concern there? She had a good pulse on this side, it was a bounding pulse. So what is the concern with that? Obviously, that can quite easily disrupt her popliteal artery. So my thought was, I'm really worried about the right knee. I don't want that to, the left knee leg, I thought, well, that's already half amputated. The right, I'm worried there might be a tear in the popliteal artery, which will occlude, and then she'll lose her right leg. All right, so those are the concerns. That's her left arm. So closed fracture, quite a nasty fracture, but it is closed. All right, so now we have to resuscitate this patient. So we have to put in a line. Okay, so obviously, you can't put in a line into her groin. You can't use the left arm, so we put in a central line. All right. We now need to decide what to do with the patient. We want to try and reduce these fractures whilst we investigate. So we put back slabs on them and we try and reduce them as best we can. It's obviously very painful for the lady. So the next step is there's going to be other people involved, orthopedic surgeons, but we need to get imaging for this patient. So we must resuscitate the patient, get her stable. You don't know what you're dealing with here, right? So there could be an injury on the left, on the right. So we need to get a CT scan. So just to take you through, we've got a CT scan. And if you go through, just have to remember, it's confusing. So it's different levels, because remember the right leg is dislocated and being shortened. So on the one side is the right, and you can see if you go down through that there are vessels all the way down. Sorry, I'm just going to stick to on the left. You can see what we didn't realize at the time, that she's got a broken tibial plateau. So her tibial plateau is broken on the left. Right. If you carry on the right, you see vessels all the way down. You carry on the left, you're seeing it at different levels. That's because the leg is shortened. You see a compound, a fracture of the tibial plateau. If you keep going down, you'll see that on the left is a popliteal artery occlusion. So remember, the paramedic said to me, "Doc, there's no pulse," and I thought, "Yeah, come on, down." Right? That's the place where there's an injury on the left. The right, if you watch on the right side, there's no injury to the popliteal artery. The knee is dislocated, but the artery is fine. So in fact, her major urgent problem is on the left. So lesson to everybody, have a flattened hierarchy, listen to, and don't exclude possibilities. Be open to information coming at you from some other source that there's a problem. All right. Okay, so there's just some more pictures showing the dislocated knee on the right with a good popliteal artery, the fractured tibial plateau on the left with a popliteal occlusion. Just some more of the same, and some more of the same. So there's the occlusion you can see on the left. Okay, so how does that change things? Well, the patient needs to go to theatre, and now we have a trauma system, because obviously we need a vascular surgeon. We've got a vascular, we've got a system for vascular surgical assistance. So we speak to the vascular surgeon, we speak to the orthopod, and the patient needs to go to theatre to have that segment of artery repaired. And there's lots of things to discuss, which you could, we could run all of these things. Should we have shunted the patient? What sort of graft? Whether we should fix the bones first or the vessel first. These are all discussions that we can now have with this team. But the lady is in theatre within 6 hours. So we know that one of the major risk factors for loss of leg after popliteal artery injury is delay. So I'm very proud of the fact that this patient was in theatre within 5 hours. So it was whatever happened, and it's not going to have a happy ending for her leg, unfortunately, but it's not because of delay. She was retrieved by the paramedics. She was airlifted here. She didn't bleed to death on the way. She had an appropriate CT scan, which didn't take a whole lot of time to do. And she was in theatre within 5 hours of her injury. All right, so the vascular surgeons repaired that, and they put an external fixator on the leg. All right, anyway, needless to say, by about day 5, the patient dropped her hemoglobin and became tachycardic and needed inotrox. Okay, so obviously now there's a septic problem. This is why we have an ICU team to support us. So it's ICU, radiology, vascular, paramedics, all of these people to support this one patient. Obviously now things are not looking good, and she gets taken to theatre, and the graft has completely dissolved. This does not reflect on the surgery. This is because that leg was, as you saw from the original picture, there was sand and leaves in that leg, so it was septic, and the pus tracked up, and the graft disappeared in all this pus. So that's it's a acceptable, it's not acceptable, but it's a understandable complication. So then we took the lady to theatre, and we did an amputation. Right. Once again, now the story's not over, because now you're sitting with that wound in a 48-year-old woman. So this now requires further team support. We've got excellent wound care sisters. We've got people with help us with these vac dressings. So you put a vac dressing on that, and you keep sucking on that wound and change it, and eventually you get that. And I haven't got the latest photograph, but that's completely healed. So the conclusion of all of this is that it's a team. And this is exactly an example of what Mandy's been saying. Overflying, came from Durban, overflew a few other amazing hospitals, and came to our little institution, was seen by me. I like to think of myself as a fairly open sort of guy and open to. I remember the paramedic just saying to me, "Doc, there's no pulse," and I sort of said, "But yeah, there's no pulse because the leg's ripped off." But I kept that voice in my head, and we came to a successful conclusion. We diagnosed the injury. The patient didn't lose her leg because we missed an injury. She lost her leg because the thing was septic and full of muck from the side of the road. So I think it's a good example of how trauma systems work and how we'd like to continue developing. And it's a team effort. Thank you very much.
Is there any questions? Any questions from anybody? Okay, we will go on to the next speaker. That is Leah Shantaprasad. I hope I pronounced that correct. Sorry if I don't. I'm going to play his presentation. I hope really it's going to work. Please let me know if there's any issues and you don't see it.
Marisa, is there meant to be?
You take from that chip that I sent you.
No, just come up
That
here.
I sent you. You take from
It is.
there.
Yeah.
Sorry, everybody, if you can just be a bit patient. Marissa's just trying to sort out the volume and the sound. There is meant to be sound. She's just trying to sort that out.
Thank you, Mandy.
Yeah, Marissa, there's still no sound, eh?
Quiet until Marisa says I can talk.
Okay, thank you, everybody. I really sincerely apologize for the technical issues. We will go to the next speaker. It's also a very big privilege for me to introduce Renee Robles. She's currently the National Quality and System Manager for Trauma and Emergency in our Trauma Division. Renee, thank you so much for your time and making it possible to speak to us about this interesting little Cowboys on Cry topic. Thank you.
Thank you, Marisa, and thank you to the organizers. So good morning, everybody, and thank you for the opportunity to share something maybe not as clinical as Prof. Clark's talk, and well done, Prof. Clark, I really enjoyed it. But I want to share, I think, something that is very close to my heart, to many of us, and in sharing, I'm going to share a little bit of myself, and I think making myself open to everybody. Hopefully there will be somebody in the audience this morning that finds a snippet of information that can add value to their lives. So I have a disclaimer. I don't own a horse, nor a cowboy hat or cowboy boots. So it's unfortunately not me in my younger days in the picture. So if anybody wants to donate me a horse, I'm more than happy to take on the offer. So
Renee, we can't hear the sound again, sorry.
Okay, Marisa, we'll work around it.
Thank you.
I have no idea how to fix the sound. Maybe, Mandy, do you know?
No, but I'm going to try my best now.
Okay, so let's see quickly. Marisa, tell me if you can hear it now.
Yes, it comes through.
Yes, we can hear it. Turn the sound up on the left, on the right-hand side of up more. Up. Great. There you go.
Okay, so let's try again. Now, I hope this little bit of music brought some good memories back for many of you. I grew up with my dad being a very fond lover of Clint Eastwood and cowboy movies. And I think, unfortunately, with the space era, cowboy movies fall to the background a little bit. But there's many books and movies around cowboys and the theme of having them as strong. And that's the idea that I had in mind. If I think about a cowboy, it's the strong riding off in the sunset after rescuing the poor vulnerable girl from this horrible villain. And for the ladies in the audience, this is, they are muscular, they're strong, they chew the tobacco, and really that is the image that I have in my mind if I speak about, or just think about cowboys. But then I thought a little bit more on who are the cowboys of today. And I think it's everybody listening this morning involved, be it EMS in the pre-hospital environment, our nursing staff, and that is from the ED all the way to our rehabilitation, our doctors, our hospital staff, allied staff, and I can group you all into a basket of healthcare workers. And I feel in my mind, if I think now, maybe cowboys of today don't wear a hat or boots, but we have the face shields that makes us a group of people together and cowboys. So then I had a little bit more thinking about the theme of cowboys, and in reading more about it, I stumbled upon, so what makes a cowboy, besides the fact that he can ride a horse, and Livermore Rodeo Association says they have inner strength, determination, camaraderie, and respect. Now, if you look at the picture that I showed on the previous slide, and you think about your own team and the people that you work with, I certainly can speak of many people that I have world of respect for the inner strength that they have, our colleagues, our friends, determined just to keep on going besides another COVID wave or 5 more trauma patients coming in. And definitely, I am very convinced about and have experienced the camaraderie and respect that we have amongst ourselves as a specialized group. However, having that special group, we are on a daily basis confronted with this two very opposite things that happens, the very sadness of death and the reality of death on a daily basis, but also the joy of life of, and sometimes it's just finding a hospital bed in the midst of the COVID pandemic, and knowing that we are giving the best that we can for that patient. And this contrast of death, life, death that happens in a 12-hour shift sometimes need to happen within the challenges of day shift, night shift, rain or shine. And I remember when I was still working quite a lot of night shifts, it's like really trying to have a day life when you're actually in night mode. And in having that physical impact on your body of changes of day, night, day, along comes the reality of the emotional impact of death and life. So I did a similar talk in 2016 for Sunninghill. And if I looked at papers then, 2014, 2015, that was published, it said there that 26% of EMS experience exhaustion, and 34% of nurses working in hospitals experience burnout. That was even before we knew the concept or the word COVID, and could not even imagine that was in a Hollywood movie where we had this virus outbreaks. But this was way before COVID. And maybe COVID just brought it more to the forefront. In my view, it was always there. And yes, I'm not denying the fact that the severe effect that the COVID disaster had on all of us working in the healthcare. But if you look then at a paper published in October 2020, it says a significant proportion of professionals reported symptoms of anxiety, and their significant proportion is 31.4%. If I look back at the two previous studies, very close to what was seen 5-6 years before this study was done. And this study was published in 2020, May 2020, also saying disorders in anxiety was 28%, depression 30.6%, and distress 20%. Again, very similar numbers in comparison on what we see. And then November 2020, very recently, the study showed that more than 1 of every 5 healthcare workers suffered from anxiety and or depression. Nearly 2 in 5 reported insomnia. Now, for the audience members sitting there, I know how many of you might be able to relate with these feelings of anxiety, depression in different stages and different levels, or insomnia of what we've been experiencing over the almost 2 years. So I had to pause a little bit after looking at this data and say, like, did things change or did it really stay the same? Did COVID change anything, brought more, or are we really facing a monster that was there for many years before COVID? And yes, I think COVID is in the news, it's in the forefront, it's all that we speak about. That's every news bulletin that you put on, you hear the new numbers, and it really pushed our staff. But again, looking at the previous slide, is it not the same, or did something really change? We speak about compassionate care and we speak about resilience, and this is even before COVID that the trauma division started to focus on, with our care program, on teaching compassionate care and teaching resiliency to our staff. And compassionate care teach healthcare workers how to practice mindfulness, compassion, and connectedness to improve well-being and support better patient outcomes. And resilience is more, so compassion is more what you give, but resilience is more within yourself. And it's really like this picture showing when you bend with the wind, but you don't break in the storm, that you can bounce back. You have your own support structure within the team, within yourself, within your family, that when you face the wind, when you face this COVID waves, or trauma patient, at whatever level you are working, that you can bounce back. And there's many courses and programs and information and ICAS and ACASs helping us with teaching our staff about how to be resilient, how to teach yourself to be resilient, compassionate, be kind to yourself, how to take care of yourself, how to take time off, and really believing that you can do it. And I'm not saying that anything of that is wrong. And I think it's really amazing what we're doing now and providing these opportunities for our staff to know more about and empower themselves and do self-care. But it's taught, not born. Resilience and compassionate healthcare workers are taught, not born. It's skills that you have to develop as we go on. And it's really skills that you need to know on how to create a positive spirit in difficult times. And it's essential, because if you can't take your own positive spirit, you can't provide that best patient-centered care. They say resilient staff thrive in the profession and ensure that the functioning and fiscal health of healthcare systems, where patients and families receive high quality self and compassionate care. And I read a lot of articles in preparing for this, and they speak a lot about how to give compassionate care to your patient, how to walk in your patient's shoe. But if you don't start, I do believe if you don't start with yourself and providing compassionate care to yourself, how can you give it to anybody else around you? And that includes your patient and the family. So this slide to me is so powerful, and the quote reads, "There's a saying we have in the emergency room when we witness trauma and death amongst the innocent. A little piece of my soul died." We're never offered counseling, and in the end, you get to the jaded emergency doctor who struggles to care. My psychologist says, it wasn't just the last girl, it was the trauma after trauma after trauma. Now, I don't know how many of you can relate to it, but for myself, I built this wonderful wall around me, higher and higher and higher and higher, to try and protect me from that trauma upon trauma. And then it's this one simple, if I say simple, I'm saying it with the deepest respect, easy case where we lose a patient who breaks down that walls, and then I come tumbling down, because you just keep on going and going and going. And a very other powerful word that I heard was after the Pulse nightclub shooting, where a trauma surgeon admitted, he says he's fine and he thought he didn't need counseling. But it's when you get in your car and you're alone when the silence hits you. And I don't know how many of you have experienced it, but surely I have. You're all good and you're all brave and you smile and you joke with the team, but you walk to your car and you close that door, and it's the monster of silence that you have to drive with. And if we don't create opportunities on how to take care of yourself, how can you deal with the monster of silence that sometimes really just eat you up? So let's stop and think a little bit about my saying on who are the cowboys of today. What makes us cowboys? So my original talk was really, how can we be compassionate and about the post-death pause that we really want to install and hope that you are doing it. But I changed it a little bit, and I think it's a lot about sharing of my view on the cowboys and what we do, and I changed it then to a different angle. So who are we? I am a nurse, I am a paramedic, you can do your own, I am a doctor, or I am a surgeon. We are a team, we are a trauma team, and it can go on and on and on, but we are cowboys. I do believe we own that right to say that we are cowboys. And what makes a cowboy? I read up a little bit more. I want to understand, and from the cowboys and the Americans and what we see in the movies, what the new age and the new modern cowboy, what are they? And the first thing that came up was the value of try. And it says what truly makes a cowboy is his refusal to give up. And I've seen it in so many times. so many staff members fighting for this patient. And Prof. Clark said in his talk, you know, just keep on going for that one 48-year-old patient. No matter what the obstacles, no matter the circumstances or weather or lack of experience or hard luck or fear, all Cowboys possesses one unique quality commonly called dry. For EMS en route, it's the middle of winter, it's freezing cold, but you keep on going. You're on a scene and it's pouring down with rain and you keep on going and going. And similar to our ED teams, it's patient upon patient, and it's later on 2 o'clock in the morning and you thought, oh my goodness, when last did I had a sip of water? And it was when you left your house at 6 o'clock to drive at hospital. But we keep on going, we keep on making plan, doesn't matter where we are and what we do. And try is well described as the blend of grit, guts, and heart we need to succeed in progressively tough times. And I really want to say, I've seen it over and over and over, and so many of our teams is that guts, the belief in we want to do better for every single patient that comes through our doors. It's a willingness to keep going when facing insurmountable obstacles. And I think COVID, it's really brought that obstacles to us. We didn't have enough of anything, but you just kept on trying one more patient every time. And it's an attitude of never giving up after experiencing failure upon failure. Can't find a bed, losing a patient, losing another patient. I was in a conversation with the Mill Park team, and at one point, the number of COVID code blues they did per day was just, I was shocked to hear that was the amount of resources, but they kept on going, kept on trying, and said, no, I'm not tired, I'm not going to run how many kilometers it feels to them per day, up and down to do resource. They did it every time for every patient. So to me, that is really Cowboy style. What makes a Cowboy? Cowboys stick with it. So Cowboys exhibit a won't quit, never give up, even if I die trying attitude. And I hope somewhere in your units, you're going to write this down. We won't quit, never give up, even if we die trying. And I think, again, I know I've seen it. I've seen it with our staff. I've seen it with EMS. I've seen it with doctors. It just keeps on working. And that is besides COVID. I see it on a busy trauma weekend, one patient after the one, and everybody just puts their head down and keep on going. So Cowboys don't cry. Maybe just a little bit when we get dust in their eyes. So it is okay, even if you blame it on the dust. So this is a book by Marilyn Halverson called Cowboys Don't Cry. And I just took a little bit about it. And the section goes about a horse that is tangled up in wire. And it goes on, and the horse tries to get out. And I want to read you this little paragraph. It says, Jeff nodded. That's right. And the same things happen to people. Life sometimes tangle you up real bad. And you've only got two choices. Live with it as best you can and try and untangle it a little at a time, or be like this poor old horse. Tear yourself up to pieces, fighting it, and still get loose. And I know, if I can speak for myself again, there's been many times in my life that I was really tangled up bad in life and things and stuff. But I could choose to struggle on my own, and yes, I will get out. But I might be badly scarred, or rely on people to help me to safely get out of what I'm tangled up into. And I really want us all to know and look out, firstly, to reach out, but also for the people around somebody that's tangled up, to reach out to that person, give them a hand and say, we're here to help you to get out a lot safer. So maybe I don't cry, but it hurts. Maybe I won't say, but I do feel. And maybe I don't show, but I do care. And I think it's so true for many of us working in trauma and emergency care. We show that we are brave. We show that we are strong. We show that we are heroes. But we are just human beings. So with a few years behind me, I know cowboys are not born. Cowboys are self-made men and women, and that's to everyone that's listening to me this morning. It isn't the hat that makes the cowboy. It's the cowboy that makes that hat. So again, in summary, you know, we spoke about the value of try, and cowboys stick with it. So for me, the next time I see a cowboy, and cowgirls, I include you, I'll take a moment to marvel at their indomitable try. And I want to ask you, if you see somebody, even without boots or blue jeans or a Western hat, who exhibits a won't quit, never give up, even if I trying attitude, you might just pay them the compliment of referring to them in a moment as cowboy. And the previous time that I did this talk, I said, maybe we need to start greeting each other every morning, howdy cowboy, and just acknowledge the never give up attitude of everyone in our team. So until that next rodeo, that next unstable bleeding, non-breathing, cardiac stroke, trauma drowning patient comes, salute and howdy cowboy. So I can't see the top screen, sorry guys, but I'll give you a moment to read this. I think it's important to see what matters isn't how we frown or even if we are found. That doesn't make us who we are. What does make you you is how you pull yourself up after you had that fall. And remember the horse that was tangled up in wires. So I want to ask you, don't try to be that lone ranger. Don't just be the cowboy hat or boots, the image of a strong, resilient, fearless cowboy. Be the cowboy that believes in the value of try, believes in sticking with it, believes in yourself and others as a colleague, a friend, a community of cowboys, because I do believe we are a very strong community of cowboys. So in ending, cowboys don't cry, just when we get a little bit of dust in our eyes. So I want to ask you, be that friend, be a community of cowboys. Start the conversation by reaching out. Put your hand up and say, I'm here to get you out of that tangled wire, but also put your hand up and say, I need help getting out. Thank you very much for your time. I'm going to end off with one last little bit of something that I want to play to you. My side, until our next rodeo, howdy cowboys. Thank you, Marisa.
Thank you so much. That was so brilliant.
Okay, that would be Dr. John Bruce. He's one of our trauma surgeons in St. Anne's and is also working at Grace. Thank you, Dr. Bruce, for being here today. And there's your presentation. Okay, hold on, I just need to share. Okay. Can everybody see the screen?
Yes, Marisa,
Yeah.
you've got to put it into
Okay.
presentation mode.
Yeah. Okay.
Well, morning. Thank you very much for the opportunity to come and talk to you guys. It's a great pleasure and honor to be here. So today we're doing, well, I thought we'd revisit the topic. And for those English language pedants around there, yes, I do realize that shot by shotgun is inappropriate because a shotgun is not a sentient being. So if you get shot with a shotgun, you get shot by somebody. However, the majority of the time, when we get the patient brought in with a history, this is what we get told. And it really does hide a multitude of sins. So it's a bit of a background on shotguns. They are a fairly unique firearm. However, if you do go into your history of firearms, you realize that it's one of the earliest types of firearms that we used with smoothbores. And essentially, a shotgun is just a modern version of a smoothbore. Okay. They carry a multitude of different loads, what people used to call non-lethal rounds. That terminology has now been revised to less than lethal, and I'll show you a few instances as to why we prefer that terminology. So they go from everything from a less than lethal to multiple small pellets, which is what most people associate them with. You know, your bird hunters, you know, you go duck shooting or dove shooting, okay, to a single solid slug. Right? And in these days, it can also carry a chemical or an electrical payload. Everybody wants to know what the velocity is. And yes, it's an interesting academic exercise. It's all good and well to know what velocity your projectiles leave the barrel at. However, that's somewhat less important. What's more important, and the question that we should be asking, is at what velocity do those projectiles hit the subject that you're shooting at? In this case, what we're talking about is our patients. Right? How fast do those projectiles hit the patient? That's really what's going to determine your tissue damage, right? Penetration and all that sort of stuff. We need to know what comes out the front of the barrel. Okay, and in terms of a modern day shotgun, it's more than just the payload or the shot that comes out. And then also the distance. Okay, why is distance important? Well, distance directly affects your velocity at which your payload hits your patient, but also the spread. Okay, as I've alluded to with your duck hunting or your pigeon shooting, okay, clay pigeon shooting, or you know, if you want to be brave and go for rocky pigeons, the distance from the barrel determines the spread of those projectiles. Obviously, with a single projectile, that's not going to spread, but your projectiles that have got multiples, the further you are from the barrel, the greater the spread, the more likely those are to act as multiple single gunshots rather than one large gunshot with multiple projectiles. As I've alluded to, this is not a new technology. If you have a look at the photograph on the top left of your screen, that's what a muzzle loader looks like once it's loaded. So you've got your barrel, you've got your powder. Most muzzle loaders are still black powder rifles, even in the modern era. Then you've got some form of over powder wad, and then you've got your payload. And then an overshot card, what's labeled as overshot card, basically is something to keep all the shot next to the powder so that it doesn't roll down the barrel if you tip your barrel downwards. Okay. If you look at the bottom photograph, the bottom left, that really is all of that just contained into a single disposable cartridge, which makes it a lot easier to load. For those of you who are into history, the photograph on the right is a modern reproduction of an American Civil War era. So you're looking at somewhere between the 1840s to the 1860s, that sort of era. And that's what your setup would have looked like. Okay, those are paper cartridges, which would load into your black powder rifle, as on the top left. The bottom left here is the so-called buck and ball, which was quite popular again during the American Civil War. You've got one large projectile with multiple smaller projectiles, which you then put over your powder, and that then comes out the barrel. On the right, in the lower end, you can see the modern incarnation of that. So really, we haven't gone that far in 170 years. So these are what most people think of when they talk about a shotgun. So you've got everything on the left, your bird shot, okay? They are made out of either steel, tungsten, or lead. There is moved away from using lead in those because of concerns about lead toxicity. And there can be anything from the high 70s all the way to your mid hundreds, depending on the size of the pellets that you pack into the case. Right? Obviously, the smaller the pellet, the more you can fit into it. The larger the pellet, the less. And you can see as we move across to the right-hand side of the picture, you'll see that demonstrated. You've got your buckshot, and of course, what everybody loves from the American movies, your double-aught buckshot. Okay, that can be anything between 9 to 12 pellets within the case, and then your single projectile on the right. The effectiveness of these really determines on what you're trying to shoot. So if you're going to go for your duck hunting, you really want something in between your bird shot and your buckshot. You're going to go dove hunting, your bird shot is more than sufficient. Okay. What does it do to our patients? Well, we'll show you some photographs of some x-rays and we'll discuss the clinical scenarios around those. But the further you are away from the bird shot, the less likely you are to have a fatal injury. Okay. Your 1 ounce slug, well, that is a single great big piece of lead. And it doesn't really matter too much what your distance is. Anything under 100 yards, 200 yards, that has the capacity to produce a fatal injury. Right. It just depends on what that hits. So now we get what everybody loves to term, riot control, or so-called less than lethal. Your rubber bullets here on the left. Traditionally in South Africa, what we used as rubber bullets were rubber-coated steel balls. Okay. The more modern incarnation of that are some high-density polymers, some fancy plastic basically, or a high-density rubber without the steel insert. And that's actually quite important. The original rubber bullets that our police were issued and our riot control units were issued with were designed to be skipped off the road, so that you would shoot on the ground in front of your people that you're trying to get to cease and desist their current behavior. They then ricochet off the road and rise up and then strike the people that you are aiming at. And the reason for that was twofold. One is if you are accidentally pull your shot high, you're still aiming at the lower half of your patients, okay? Because they will become patients, right? And if they do strike the road and rise up and ricochet off, they've lost an enormous amount of their velocity, because that act of ricocheting off the ground robs the projectiles of a lot of velocity, and then you are less likely to get penetration from these. So you just wind up with soft tissue injuries only. The downside to that is that you actually need quite a lot of training, because as soon as somebody picks up the firearm, what's the first thing you do? If you aim it, is you aim down the barrel and you aim at the lethal part of a human being, because that's an innate problem. The result of shooting somebody at even moderate range with these rubber-covered steel balls leads to multiple craniofacial injuries, head injuries, and can wind up with significant pathology in your patients. The more modern true rubber balls are a lot lighter, so as they come out the barrel, they lose their velocity a lot faster, and the rounds are loaded to a lower velocity to start with. Okay. And the idea being that they are less likely to be lethal, hence the change in terminology to less than lethal, but they're still aimed, you should be aiming them at the lower half of your target. You shouldn't be aiming them at the head and the chest area, okay, for the same reasons. We don't have these widely available in South Africa, but elsewhere you've got baton or beanbag rounds. That's basically a Kevlar little bag, which is filled with very, very fine lead dust. That's very malleable, so that when it strikes the target, it opens up and stretches out to be a very large area. Again, trying to reduce the chances of that then penetrating through the skin, but still able to create enough pain to get your target to cease and desist, because that's really all that they're trying to achieve with these rounds. Some of the newer technology, again, not really available in South Africa widely, but they are available elsewhere. On the left here, you've got a little rocket-shaped projectile, and that's loaded with CS gas, which is an industrial version of tear gas. The idea behind that is that it's got light barrier penetration capability, so you can shoot it through a pane of glass in a car or in a house, and then as it goes through, that ruptures and it releases the gas within the room or within the vehicle. Right? And anybody who's ever been exposed to proper CS gas will know that only the most hardened will be able to continue doing what they're doing when that's within any proximity. Okay? But again, that's not in direct anti-personnel use, so it's supposed to be an indirect use weapon. On the right, you've got a taser. Taser, I'm sure you guys are all aware, is sort of handheld stun gun, but you can use it at a distance. They've now been able to miniaturize that technology so that it fits within the hull of a shotgun shell. So that you can actually launch this out of a shotgun, so you can be 30 yards, 40 yards away from somebody and you can tase them. And it does actually work remarkably well. There are obviously issues with the use of these electrical devices in certain patients, but overall are thought to be more specific and safer overall than the use of rubber bullets in a similar situation. So why do we care about all of this? Because ultimately those people who wind up getting shot, either rightly or wrongly, we don't judge or discriminate, but they become our patients. Okay, and we need to know about this because we need to treat these patients. The recent unrest in KZN and other parts of the country brought us an influx of these injuries, everything from ultimately benign to fatal injuries. Everything, and again, from birdshot, buckshot, all the way through to your supposedly less than lethal rounds. We have had fatalities from those as well. We've covered most of this, but your clinical effect is determined by the initial loading, the speed and mass of your projectile, and then what its aerodynamic ability is. Like you've seen examples on the taser, when as it comes out the barrel, it deploys little fins at the back to get it to spin. And one that keeps it accurate, even out of a smooth bore, those are very accurate out to 30, 40 yards, but it also slows the projectile down. You don't want that to hit somebody going too fast, otherwise you'll find that taser embedded in the patient, and that really is not what it's designed to do, and it's very bad for your patient. Okay. Then your distance from the firearm, we've already covered that. And then ultimately, do you have one projectile versus many? And the simpler version of treating these patients is if you've got one projectile, because that narrows down what you need to look for and what you need to treat dramatically. Multiple projectiles cause multiple problems. So this is what it looks like when you get shot by multiple small projectiles from a fairly large distance. So that's an AP chest X-ray of a patient who's been shot with what we colloquially call birdshot. Basically, you eyeball it. There's no specific parameters that we use in clinical medicine in terms of what you get shot with, but this would go through under the colloquialism he's been shot with birdshot. And you can see that these pellets are scattered throughout the chest X-ray. They're not really centered around much other than you can say that he was probably impacted from the left, because the majority of those pellets project on the left of the X-ray. The chances that these penetrate deeply is somewhat less, and given the spread, you can assume that this was shot from a fairly long distance away, or from a very short barreled firearm, which essentially is the same effect. This is what it looks like clinically. You can see this young man was shot again with birdshot. That's the right arm. You can see the posterior aspect of his right arm. He presented to us about 5-6 days down the line, which is why those wounds look like they're healing. Okay, he was worried and wanted to know if we could go and retrieve the shot out of his arm. Obviously, that's not something that is clinically feasible. Fortunately for him, he didn't have any neurovascular concerns or damage as a result of this. But you can see on the X-rays that some of those pellets have penetrated a lot further than others. Some of them gone all the way from the posterior aspect of the arm and now sitting in the anterior aspect within the biceps. So while that penetration in terms of hunting isn't great, in terms of the clinical effect for this patient, it is a problem because they pass beyond the nerves and the vessels in the arm. Okay, and that's all it takes, is it just needs to have one that goes through the vessel, and then you've got a problem, or to hit the nerve, and then you've got a problem. So that penetration, albeit from a fairly large distance, was more than sufficient to cause this man a serious effect. And if you're delayed in coming in with arterial injury, we might well be talking about the need to do an amputation. So this is what it looks like when you've been impacted from a sort of more moderate range, so you're not quite as far away as the previous images. And as you can see here again on your X-ray, this is the scanogram from a CT, and we'll discuss now why we did a CT on this patient. But you can see that your shot is in varying distances. Now you don't know if those are just projecting the AP and they've penetrated that far on the lateral or not, which is why with these patients a CT scan is of value, because it can then tell you where those pellets are, and you can find out how far they have penetrated, and therefore you can work out what structures you need to be concerned about. In addition to that, you might want to do other specialist radiographic investigations. An example of this is a swallow. This is the same patient. He had a bit of dysphagia, and you could say, well, yeah, you've got a whole lot of pellets in your neck. Obviously, you're going to have pain on swallowing. But because we've got a system and we follow it through, you can see we did a swallow for the patient, and that sort of lime green arrow points to a hyperpharyngeal leak as a result of pellet penetration. On its own, that's not a fatal injury. So the treatment for that is, by and large, is conservative with a very good outcome. But you miss it and you don't treat it appropriately, this patient is going to come back with a necrotizing fasciitis of the neck, and his mortality for that is dramatically increased. You're going to be looking in the high teens, if not 20% mortality rate, whereas if we treat this appropriately, even with conservative management, the mortality rate is going to be well below 1%. Just to carry on, this is the same swallow. You can see now we've got the contrasters down in the stomach, and you're looking over the liver, and you can see there you've got pellets which project over the liver. And on the CT scan, you had 1 or 2 pellets which had penetrated through the abdominal wall and were sitting within the liver. Again, if it's sitting within the liver, it's very easy for those pellets to project, to go through and to cause a bowel injury. It's gone into the liver, it can go into the bowel. Fortunately for this patient, he didn't have that, so we didn't need to do a laparotomy for him. So now we move a little bit closer. Okay, so this is a young man, circumstances unclear, who presented with a single shotgun injury to the right leg. And as you can see, that the shot is much more concentrated. You can have a look at the clinical picture down below. You can see there's a large central defect, and then a few satellite defects around the side. So as that shot opens up, there's a large mass of it still continues together, but you start getting your individual pellets peeling off the side out of that central column of shot. And this is what it looks like. Now, obviously, that wound needs to go to theatre. You can see there's devitalized edges that needs to be debrided, washed out, and we need to go and check for other foreign bodies. You remember I said we need to be aware of what comes out the front of your firearm when you get shot with it. In the case of a shotgun, there is a plastic, usually it's some form of plastic or polymer, what we call a wad and a shot cup. They're often combined into one unit for ease of manufacture, and that also comes out. That's what contains the projectile as it moves down the barrel. The problem with it being a plastic or a polymer is it doesn't show up on X-ray. And that now becomes a problem because we don't know that it's there. But in a wound like this, we're going to take the patient to theatre anyway. And one of the things that we need to be aware of as surgeons is you need to make sure that you follow the central trajectory of that wound through the muscle and go and find out, is there a retained foreign body that you couldn't see on X-ray? And in this case, we did have the entire shot cup was stuck inside the leg, and that was successfully removed. We don't remove it, then we're going to sit with ongoing sepsis that we're not going to get on top of, and we're not going to find it on a X-ray. So your fallback plan there is to try and get a CT scan. It'll pick up some, but not all of them. Ultimately, if you still can't get it and you can't find it on surgical debridement, then you might actually need to go for an ultrasound. The ultrasound will pick it up because it can differentiate between the density of the muscle and your plastic much better than what an X-ray can. So it's just something to be aware of. So this young man was brought to us having been shot at very close range into the abdomen. What's notable on the X-rays, we start on the X-ray on the left, the bottom right-hand corner of the X-ray on the left. Okay, I hope you guys are following me. You can see there's a big concentration of shot that is sitting there. That's actually transected. We were shot just below the umbilicus in the midline. That shot has gone through the left iliac fossa and has exited, and it's actually gone just above the iliac crest on the left, and it's sitting within the muscles. Right? And if you have a look at the rest of the shot up onto the left upper quadrant of that X-ray, you see that loose shot that was floating around within the abdomen is actually following the implantation of the mesentery of the small bowel. So as that shot went through the patient, some of the pellets lost their velocity and remained within the abdomen and were distributed, as you can see, but a significant proportion then went through and created a dramatic soft tissue injury, which you can't actually see from outside the patient. You can only find that at laparotomy. The X-ray on the right is the same patient after his third debridement. Okay, so you can see we've successfully managed to take out most of the shot floating around within the abdomen, but you can still see that there's a large portion of shot sitting within the left lower quadrant on the X-ray. And if you go even closer, this is what it looks like if you shot at very close range. You start on the X-ray on the left. This patient was shot from the right-hand side. And you can see that the shot's actually gone almost all the way through the leg. And we found the majority of the shot sitting under the skin on the medial aspect of his right leg. As we move to the middle X-ray, you can see that the shot's gone through. There's a femur fracture hiding there. And there's a large metallic foreign body, which is next to the cranial wire. That's actually part of the car door that the patient was sitting in a car and he was shot through the car door. That's part of the car door that got entrained into the wound and got pulled through into the wound. And as you can see again, that's on the medial side of the leg. So it's not just what comes out the barrel, it's what else gets picked up along the way and then gets dragged into the wound. Gary mentioned earlier about the utility of tourniquets, and that's something that's come into clinical practice. If you have a look at the middle X-ray there, you'll see that there's a nice indentation just above the femur fracture, and that's a tourniquet that was applied by the treating paramedic on the scene. And this is a patient who was brought to us by aeromedical transfer from Durban. Without that tourniquet, he almost certainly would have bled to death. His femoral vein had been ripped apart, and he had two distinct areas of injury on his superficial femoral artery, which needed debridement and repair. Without tourniquet and without very rapid access to the patient and bringing him into a system that can deal with him and with the magnitude of trauma that he had, this patient almost certainly would have been dead on the scene. I've mentioned the use of CT scan. So this is a CT scan of the same patient. Just a few cuts just to illustrate the point. So here we're looking at the leg on the right, so it projects on the left-hand side of the screen. You can see that that leg is significantly more swollen than the other leg. Right? You can see those bright highlights with scatter. Those are a few pellets. You can still make some clinical assessment of this leg. And on the medial side of the leg, below the two pellets, you can see that there's another bright white light. That is his femoral artery. So you can see the patient still has flow in his femoral artery at this point. There's a limitation to what your imaging can do, however. You can have a look at the images here. There's so much scatter that at this point you cannot make a determination as to what's going on with the vessel. Right? So everything does have its limitations, and definitely on the bottom picture on the left there, you can see there's so much lead in that leg that you cannot see whether that artery exists or doesn't. At this point, from what we can ascertain, we operated this patient, the femoral artery is actually intact and still has blood in it within that mass of lead, but you can't see it. Right? So this patient then went off to theatre and subsequently kept his leg, fortunately. So that's now all about birdshot. Okay. So another patient who was brought in, and this would now colloquially be known as being shot by something or with something akin to buckshot round. Okay. He was struck with a single pellet. You can see that the pellet entered on the patient's right, sort of right below the clavicle, and has gone all the way through the chest, gone through the scapula, and is now sitting and was actually palpable on the backside of the scapula, just under the skin. So that's significant penetration, and as you can see in the images, managed to injure the subclavian artery. So it doesn't take much, it just takes one pellet to hit you in the right spot, and then you've got a significant injury. Unfortunately, this patient was able to get the surgery that he required to repair his subclavian and has subsequently done well. Our so-called less than lethals. Right. So this is a young man again who was injured in the unrest that we had earlier this year. You can see he's got an X-ray of his femur and then of his hand. So despite having had previous surgery to fix his ulnar styloid on the hand, you can see that he's got a retained foreign body with 2 fractures associated with that. Okay. On the leg, may or may not project very well, but there's a very vague hyperdensity in the soft tissue there. And this illustrates the two, so despite being the same patient being shot at the same time, illustrates the 2 different types of so-called rubber bullets that are on the market at the moment. The one in his hand is obviously extremely dense. That's your rubber-covered steel ball, whereas the one that's in his leg actually is just a total rubber or high-density polymer ball. So what do these look like clinically? The photograph on the left is the one that we took out of the leg. Okay. That literally was just sitting through the skin and just in the fascia, hadn't penetrated the muscle. I was able to remove that with my gloved fingers very easily. We did take the patient to theatre to debride the wound, but by and large, that's not a terrible deal for the patient. The injury on the right-hand side of the screen is his wrist. So what you can see coming out of the top wound, it's a tendon injury. Okay, that's part of one of his tendons that have been injured, and the bullet's gone through the in between the two metacarpals and had fractured them, and was actually palpable on the palmar aspect of the hand, despite him being shot on the dorsal aspect of the hand. So again, just to illustrate, same shooting, same distance. The one didn't penetrate particularly far. Sure, he's got a soft tissue injury, you can have a soft tissue defect, but that's something that you can actually sort out under local in your ED. Right? You can choose whether you want to observe them or not, but that's a fairly minimal soft tissue injury. The other one is go to theatre, spend a good 20 minutes trying to extract this rubber bullet from deep within the palmar fascia, wash out, debridement, and then take them back at a second sitting to go and try and fix his fractures. So significant difference between the two. This patient, again, is from June, July, and he's had a single injury with, again, a so-called rubber bullet. And on the CT scan, on the picture on the right, you can see what I'm saying about it being a steel-covered rubber-covered steel ball. You can see on the picture on the left, that's gone, created a fairly significant defect in the skull, so quite a bad skull fracture, and has penetrated deeply within the brain. So these aren't non-lethal. Okay, this patient did manage to survive, but he does have significant neurological deficiencies, as one would expect. This patient was injured some time before June, July. In fact, it was December last year. We were phoned, brought in shotgun injury, and this is the chest X-ray we had. You can see that he's got an intercostal drain on the right, CVC on the right, and then these two foreign bodies sitting on the medial aspect of his right chest. The holes were on the lateral aspect of the right chest. At the time, we couldn't see any rib fractures, and we weren't really sure where these projectiles were. So the patient was subjected to a CT scan, and there you can see these two projectiles sitting just above the diaphragm, where the diaphragm, the liver, and the pericardium come together in the right chest. So what you can see on this image, between the two foreign bodies, you can see that's the start of the pericardium, which is sitting there. He did have a significant pericardial effusion and presented as if he was in a cardiac tamponade. So the patient was taken to theatre. He had a thoracotomy. And this is the picture on the right, is the injury through the lung. Okay, so that projectile had gone between the ribs, through the skin, between the ribs, all the way through the lung. That's what the hole looked like through the lung, and that's approximating 3/4 of an inch in diameter. Okay, so it's a fairly sizable hole. The next picture is the pericardium, which we've lifted up, and the reason I'm showing that is that there's no defect in the pericardium at that point, but it struck the ventricle with enough velocity to create a big tear within the ventricle, which is outlined as in the picture, that we needed to repair. Now, obviously, there was a lot of blood coming out of that. When we opened the patient, so we don't have a before picture. We sorted the problem out and got you the after picture. The point behind this is never assume a less than lethal injury cannot kill a patient. Right? This didn't penetrate the heart, but struck the pericardium in the heart with enough velocity to rupture that myocardium. Okay. Again, if the doctor who was on, I was called late into this case, the diagnosis had already been made. If the guy who saw this patient initially wasn't awake to all of these issues and aware of some of the problems and investigate this patient appropriately, nobody would ever have thought that this would be the outcome. Okay. We were able to at least get this patient to come off the table, with significant issues with his renal function, okay, which is not unexpected, okay, in this particular situation. So we must just be careful with shotgun injuries. We need to do our due diligence with these patients. As has been asked from you before, are we not at risk of over-investigating these patients? I hope with the images that I've shown you that we're not really at risk of over-investigating these patients, especially with multiple projectile injuries. We have no idea where each one of those projectiles has gone. Even if your payload is only 70 little lead spheres, trying to track down 70 individual tracks is not something that you can do clinically. Okay. So we need to investigate these fully, and if that means that we need to take the patient off for X-rays, that's fine. Please X-ray more than what you think you need. Right? All it takes is one of those pellets to be a little flyer that's outside of the group for whatever reason. Maybe it was deformed during manufacture, and that's the one that's going to cause your patient the problem because you haven't investigated this patient completely. So we start with a thorough clinical examination, try and track down where all of these holes are, and then we image those areas as appropriately. CT scan, I've shown you that it's very useful. Okay, it definitely helps, but it also has significant limitations. Right? We need to be aware of those, and we might need to resort to other types of radiological examination, such as ultrasound, Doppler, angiography, etc. Okay. If you do take these patients to theatre, one has to be very cautious about how you explore and what you explore. If you go back to the patient with a piece of car door in the leg, the one I showed you guys the CT scan of, we opened that patient, we found destroyed femoral vein and a significant deficiency in the wall of the superficial femoral artery. We were able to repair that. We then went to go and look further, proximal to our repair, way beyond what we had initially thought would be the area of injury. We found another 2 bullet holes through the artery. That was then repaired with a vein patch, and the patient was successfully being discharged with his leg. If that hadn't been done, if we hadn't gone and looked just a little bit further, we would have had a repair that would have clotted up. We would have blamed our surgery. In fact, it wasn't our surgery, it would have been a missed injury. Still a surgical error, but it's not an error in the repair, okay, which is what's going to be the assumption. Okay. But if we hadn't just taken that step further, and we almost took that step further just based on protocol. But we know shotgun injuries are bad, we know they've got injuries further than what we often find. So let's just go and make sure that we look. Right? So we followed the rules. Okay. That did bring about a successful repair for this patient. And please just bear in mind that you can have significant trauma from the so-called less than lethal rounds. Okay. Thank you. Any questions? Yes, sir.
My only question is that in your exploration of the bullets, if you're able to find all of them, what happens to the patient?
Okay, so for our remote audience, the question is, on exploration of the patient, if you're unable to find all of the bullets or the pellets, what happens to the patient? It's a good question. We don't go and chase individual projectiles because the harm that you cause trying to access them is outweighs the benefit of trying to remove them. Having said that, during your debridement, you must try and take out as many of those pellets that you come across as possible. Definitely in South Africa, the majority of our shotgun shells, including our bird shot, contain lead. And there is a problem with lead toxicity in these patients, especially if they have a significant number of pellets remaining. I cannot give you a value as to how many are too many, okay? But definitely from our service, we now move towards doing lead levels in these patients at 3 months, okay? The next question you're going to ask me is, what do you do if he's got lead toxicity? And the answer is, seems to be chelation, right? So you try and chelate it as if it's from some other exogenous source. The problem that we have at the moment, and definitely in South Africa, is that nobody knows whether you should go and try and reduce the burden of lead that the patient has, or the patient is just going to sit with lifelong chelation. And even in the international literature, that's very controversial. Nobody actually knows what to do with that. So for the moment, the standard of care is chelation and ongoing monitoring of your lead levels. Any other questions?
Is there any questions from our audience from Zoom? There's quite a few compliments. Sorry, was there somebody trying to say anything?
No, I just said no, but thank you. That was a great talk. Thank you.
Thank you.
Thank you. Okay, our next speaker, Mandy, would you be able to sort out our dietitian yet, or can we go on to our nutrition? Our physio talk, sorry.
On to nutrition, and we'll try the dietitian, the physio last, okay?
Will do so, thank you. So the next speaker I'm going to introduce is Omi Naidu. He's one of our dietitians into St. Anne's Hospital. I'm just presenting. Omi, can you unmute? Can you talk to us?
Hi, Marissa. Can you hear me?
Okay, perfect. We can hear you. I'm just going to present your presentation now. Okay, can you see it, Omi?
Yes, I can. Would you be able to put it into slideshow?
There we go, done.
Okay, perfect. Should I start?
You can start, thank you.
Okay, so it's a good morning to everybody. I'm not sure if it was strategic that the dietitian and the nutrition component is coming very close to lunch. So I'm going to try and keep it short and sweet and to the point. I'm a registered dietitian, as Maritza said, and I'm based in St. Anne's. This presentation was presented or done by one of my colleagues, and I've then added a few things into it. And it would have been ideal. I'm not sure, Maritza, if we're able to sort of ask a question currently to the audience.
Yes, you can.
Okay.
I don't they're all
Okay.
muted.
Okay.
Yeah.
Yeah, but just to ask, when we hear nutrition in trauma, what sort of thoughts come to mind, if any? Maybe you could get it from the room there, Maritza.
I mean, I just can't see because I'm presenting. So if they can talk, I'll appreciate it.
Oh, okay. Okay. I thought you were in the room. TPN. Okay. Somebody says TPN. Okay. Yes, that's definitely the Irene says TPN, and that's obviously plays a massive role. But my hope and my aim for this talk today is to hopefully leave the audience with a message that nutrition is no longer just for sustenance of the patient, or when the patient is better, then we give them enough food or enough nutrition. There's a wealth and a plethora of data that's showing us that adequate nutrition from day one in trauma or in any critical illness is something that can change the outcome of the disease. So it's no longer just sustenance, but we're looking at 90-day mortality, readmission rates, and various other endpoints, which nutrition, a simplistic intervention, can definitely change, affect, and have a positive impact. In terms of, if you could go to the next slide. In terms of disclosures, I receive honorariums for speaking for the various companies, Nutricia, Baxter, B. Braun, Nestle. I also host a clinical podcast for dietitians, and for that I receive sponsorship from the various companies there. And the podcast is available on all major platforms and listened to in more than 20 countries. And just lastly, I also receive speaker fees from various media brands such as SABC, DSTV, and various other platforms. And yeah, that's basically the disclosures. I wanted to start the talk discussing hospital malnutrition, and just to take a step back and understand hospital malnutrition. When we talk that, we're meaning it's an imbalance in nutrition that results as a consequence of inadequate intake, impaired absorption, loss of nutrients due to the illness or trauma, as well as increased metabolic demands during illness. So it's well noted that trauma is very catabolic, and being catabolic, it then predisposes these patients to a higher risk of being malnourished whilst in hospital. The prevalence ranges from around about 7% to about 76%, which doesn't tell us much. But in terms of trauma patients, it's actually 60% and above that are affected at some point in their stay, where when we do a validated screening tool, you can see that they fall into the category of malnourished. We know that with the geriatric trauma patients, we have a higher incidence of hospital malnutrition because these old, frail patients often come in at a very low nutritional status. So if we're thinking of our elderly patients with their falls and those kind of injuries that come in through the ED, these are patients that we should be looking at very quickly and very timeously to intervene in terms of nutritional. You could go to the next slide. So when we're looking at what is the impact, so the patient has a poor nutritional status. So what, Omi? I've even had a consultant ask me, so what if they're not taking in well at this time? And so what if they have low muscle stores? Our job in the emergency setting and our job in ICU is to make them survive it. But however, having a poor nutritional status is associated with negative outcomes for the patients in terms of higher infection rate and complication rate, increased muscle loss, impaired wound healing, longer length of hospital stay, and lastly, increased morbidity and mortality. So yes, nutrition is somewhat not as important in certain spheres of thoughts, in certain types of emergency medicine, but we've got to think of it as not an all or nothing, but working together with the other sort of disciplines to help the patient improve their outcome. Move to the next slide, please. So it's quite coincident that we're talking hospital malnutrition because a week ago was World Malnutrition Awareness Week. And as mentioned, malnourished hospital patients are associated with longer hospital stays, higher medical costs, and increased mortality. So the biggest concern I get, I normally talk to quite a few specialists, and my job as a dietitian is to advocate for better nutrition care for all the patients. And part of advocating is creating an awareness to the problem. And the biggest thing is when I show studies to doctors or when I show studies to to specialists, the common feedback that I get is, Omi, a lot of these studies are international based. So I don't think our settings are as accurate as what you're trying to present. Or I don't think our situation is as bleak as what you're presenting here. But quite interestingly, I found a lovely study that was published in 2019. And if we could go to the next slide. It was a study that looked at hospital malnutrition in the African continent. It was one of the lead study investigators was Professor Renee Blau from UCT or Stellenbosch. And what they basically looked at was academic hospitals. So hospitals that are known to be very specialized, have hands-on protocols and enough manpower and staff, things like Tygerberg and Critiscure hospitals, where they looked to see what was the incidence of hospital malnutrition. It was purely an observational study. They weren't looking to intervene in any way, but they wanted to see how big was this problem. Go to the next slide. From the study results, so a local study, 3 big academic hospitals in South Africa, what they found was that 39% of the population that came through the hospital were well nourished, but an alarming 61% were at risk for malnutrition. And there's various studies that have shown that if you're at risk for malnutrition, it still has all the negative impact that we discussed in the previous slides, the reduced wound healing, increased risk for morbidity and mortality. And what they looked at the study, and what was even shocking, so we're talking academic hospital, good systems in place, was that on admission, if you could see the pointer here, on admission, the at-risk population was 61%. But after the admission or on discharge, it actually went up to 71%, telling us that even in specialist units or specialist hospitals, very little was done to actually intervene or to improve the nutritional status of these patients. Could go to the next slide, please. One of the other findings that they had from this study was that only 2 in 10 of the patients at risk for malnutrition were actually referred for nutritional support. And even worse was that only 8% of the patients were referred within the first 48 hours. So the reason I mentioned this is that all guidelines tell us that when a patient has been flagged at risk for malnutrition, we need to intervene quickly and timeously so that we can improve the outcome. So it was shocking to see specialist units in our country, local data showing that we've got a problem. There is a problem of hospital malnutrition, but there's an even bigger problem in terms of our systems not being able to pick it up quickly, intervene and improve the outcome. If we could go on to the next slide, please. What they also looked at the study was to try and identify what kind of departments were having the biggest issues, what kind of disease conditions or diagnosis. And from this, they showed the biggest problem or the highest incidence of hospital malnutrition was firstly from infectious disease. So it was no surprise, your HIV, your TB, internal medicine featuring very high there, neurology, nephrology, gastroenterology. But you could see there's somewhere midway between all the different diagnoses. Round about the 49% was our surgery and trauma. So showing us that, whilst internal medicine had the biggest issue with hospital malnutrition in this specific study, trauma didn't feature too far off, 50%. So 1 in 2 of them were at risk of malnutrition. If we could go to the next slide, please. Okay, so when we're looking at nutrition in trauma patients, I thought it'd be interesting just to give an overview of what our guidelines tell us. We know that for moderate trauma, they should be getting to 1 to 1.5 grams per kg per day of protein. And in terms of calories, we should be giving them at least around about 25 to 30. When we move on to severe trauma, our protein recommendations can move up to 2.2 to 2.5 grams per kg, and the energy can go up even further. And we may at that point even use enhancing diets that contain things like arginine, glutamine, omega-3, and various other immune modulators to help to suppress the inflammation in the body, but also to improve wound healing and other things that may be needed. Again, just the take-home message is that we know trauma is highly catabolic, and the role of a dietitian is to meet those requirements, but also to provide enough of a substrate to allow for wound healing and wound recovery. Next slide, please. So we know that, as I said, trauma has higher requirements, but we know that we get protein losses, which can occur via the chest to abdominal drains, severe skin damage, protein urea. They may have intestinal secretions, but the biggest mechanism in trauma often is the higher rate of protein breakdown. And we see this immobility, the decreased nitrogen efficiency, steroid administration, and decrease of intake being the biggest factors that increase protein breakdown. If you're looking at the energy requirements, we know it's catabolic, and the higher energy expenditures due to various factors within the metabolic system that causes your patient needing more energy and more protein. If we could go on to the next slide. When we talk of screening tools, so these are validated tools. So there's a host of tools which can be used. So the reason these tools exist is that the sad truth is when we think of hospital malnutrition or when we think of malnutrition, we all have our preconceived bias of how that patient looks. If I were to ask you just to entertain me for 5 seconds, when we think hospital malnutrition, if I were to share my own preconceived notion, I walk into a cubicle, I see a patient very emasculated, his protein levels are low because we can see his bones featuring quite high. He has very little muscle tone. He has a sunken eyes, cheekbones showing, and he just looks generalized, ill, or almost old. When we look at the sticker and we look at what his age is, it's like a vast difference because he seems so much more aged because of his nutritional status. I'm sure we'd all agree that that's sort of the picture that comes to mind when we think of hospital malnutrition. But the sad truth is that the biggest risk or the biggest problem is not those that we can easily see with our eyes, but it's the ones that we need to actually look at what they've been eating previously. We need to look at what type of infectious disease they have. We need to look at how much of muscle they've lost in the past months. Those are the patients that actually do have a high risk or are actually classified as malnourished, but don't look at. So very often we have the feedback from the nurses saying a patient doesn't need a supplement or they're eating well, so they should be fine. But very often these overweight patients, we may think they have enough of a reserve, but they actually have something called sarcopenia, which we'll discuss shortly, where they have a high fat mass, but their muscle mass is extremely low. And that classifies them as somebody who needs nutritional intervention. So just to answer your question, or just to put it in perspective, screening tools are there because specialists in the nutritional realm have done research validating it on various thousands of patients to use a tool where it's regardless of whether it's Omi Naidu in Pietermaritzburg or whether it's Joe Soap in Lebanon. When they answer those questions, they can get an objective score as to whether this person needs a timeous intervention or not. There's quite a few tools out there, and the most popular one or the common one that we use in our practice is the NRS, Nutrition Risk Score 2002. If we could go to the next slide. In an ideal world, this is basically the tool. In an ideal world, nursing staff would be doing this tool and then highlighting to a dietitian which patients need to be seen. However, we know that nursing staff are currently burdened with lots of other tools and other duties besides just patient care. They've got other tools that they need to fill out and lots of admin that go in their role. So in our practice, we take the lead and we make sure that when we see a patient, we do the screening tool. It just basically goes to simple things in terms of weight loss, nutritional intake, trying to grade the severity of the disease, and essentially then giving them a score. What's quite interesting to understand as well is that a patient may come in to hospital and not be at risk, but I could screen that patient in another 2 weeks, and when we look at them then, they then fall into the malnourished category. And that's just due to the severity of illness and the lack of intake during an acute stay in hospital. If we could move to the next slide, please. Then we're talking about sarcopenia, and this is your progressive and generalized loss of skeletal mass and strength with a risk of adverse outcomes. So this ties in directly to mobilization. It ties in directly to getting your patient back to a better quality of life or functionality. And what it's also shown is that when your patient has sarcopenia, they do have a higher risk for mortality. We could move on to the next slide. So if we're looking at the impact of sarcopenia in trauma patients, I'm not going to go through everything in terms of this slide, but essentially just knowing that if your patient has a low muscle mass, it's a strong predictor of out-of-hospital mortality, especially among the older adults. And we know that when your patient has sarcopenia, they also have a higher in-hospital mortality. If we go to the next slide. I just thought I'd include this. This is a patient that was recently discharged this week. He had spent at Mediclinic 150 plus days due to COVID pneumonia. He had a long journey with us and we were quite excited. He was one of the few that was able to get home. I just thought I'd illustrate, the impact in terms of muscle mass. I've got 2 arrows there. And if you'd agree with me, you'd see there's very little muscle tone for this patient. He's been immobilized for a long period of time. He's had several catabolic hits, very similar to our trauma patients. He's had times where he couldn't take in enough protein, enough calories, and all that leaves the body doing is eating up his own reserves in terms of his muscle and fat. But ultimately, my question would be, what type of functionality is this patient leaving our hospital with? What type of quality of life? And it's our role, while we're working with these patients as dietitians, our role is to ensure that we can try our best to preserve muscle function and muscle mass, but also then to think about what happens after hospital to create these recovery programs, because the journey just begins when they get discharged. Next slide, please. I thought I'd just share also what some of the trauma patients say, and this was from a study in 2014. I don't know if it's something that happens if you've only been in ICU a few days, but your body feeds off your muscles. I didn't know any of this. Had I had the knowledge, it would have been easier for me to accept this. Just talking to, the actual psychological state of a patient who probably wasn't aware of what was going on in terms of the catabolic effect of trauma. And it's our role as dietitians when we do counsel patients is to advise them to set reasonable goals, because this can impact on their psychology or on their mental health if they're going to feel depressed that they're trying their best to eat, but they're not getting back to functionality. Another patient said, when I first got home, I got the shock of my life. I could put water in the kettle, but I couldn't lift it. That's when I said to yourself, you are bad. And lastly, another patient said, I was glad to be home, but very, very tired and very weak. I had to rely on someone to get me up, dress me, and that sort of thing. And it just talks to the fact that, yes, in trauma, we do great work while the patient is in hospital. But I think a lot of the time, the journey for the patient himself or herself actually begins when they leave our setting, whether they go to a step down or whether they go to home. And this is why nutrition in the recovery phase as well is extremely important. You could go on to the next slide. I just thought I'd touch on post-ICU syndrome or PICS. And this is basically features where we look at somebody who's got, after being in ICU for a prolonged period, they've got 3 parameters, and that's physical impairment, cognitive impairment, and psychological impairment. From our side, the physical impairment is very, very common. And we see it, the studies showing that 25 to 80% of the ICU patients may end up with ICU acquired weakness, critical illness, polyneuropathy. And, the cognitive impairments and the psychological impairments also impact on the patient's nutritional status. They may have a loss of appetite due to their mood. Due to the cognitive impairments, they may forget to eat. And there's so many things that all tie into the nutrition. If we could move on to the next slide. This is just a study where they looked at the impact of trauma or sarcopenia in trauma patients. The long and short of it is we're not going to get into all of it, but the long and short of it was that 66% of the patients were sarcopenic. So they're telling us there is a problem in terms of sarcopenia. And they either died or had poor functional outcomes at discharge. So telling us sarcopenia ties to mortality, sarcopenia ties to functionality. And we're hoping that as time comes, we can implement new technology that can actually have a better system to monitor the muscle mass in these patients. A simple example is in St. Anne's. I know some government hospitals. In St. Anne's Hospital, as much as we private healthcare, at the moment, we don't have something such as bed scales. So measuring these patients' weight, their muscle mass, those kind of things always becomes a challenge. So we're hoping with time to improve on this, and we are actually putting in systems to actually monitor muscle mass, because this is something that has various impacts to these patients. Next slide, please. when we're talking about the recovery phase, and this is typically where, post ICU length of stay is often 3 to 4 times longer. So our patient leaves the ICU, everybody, cheers on, they're out of the critical setting, their trauma seems to be improving, and now they sit in the ward for maybe even longer time, 3 to 4 times longer. If we could move on to the next slide. When we're looking at, if you could go on to the next slide as well, when we're looking at nutrition in the recovery phase, and this is just a slide where, if I were to just start from the beginning, on the left-hand side, in our acute phase, so your patient is post-resus, we know we don't need to feed them too aggressively, we don't need to get up high calories, but we do need to try and push protein. Then the patient stabilizes by day 4 or 5, and then we start to give them their full requirements. But what the studies show us that after day 5, after day 10, sometimes these patients need even more protein and they need more calories. And very often this stage, the post-ICU and the post-discharge, often coincides when the patient is deemed from a medical perspective as a lot more stable and requiring less input from medical practitioners. So the dietitian may not see them daily, they may see them once a week or once every 3 days. If they post-discharge, the patient may come once a month if we're lucky. But the sad truth is that in this time where we have less interventions, the patient's requirements is even higher. And what we find is that because they need so much and there's less interventions, we actually have patients that don't meet these requirements. And this is why they often lack the functionality or the muscle mass after their illness or after their trauma. If we could go on to the next slide. The next part is, we're rounding up towards the end now, is we're looking at oral nutrition supplements. And these could be your enteral nutrition. It could be things that you use like nasogastric tube feeding, or even just your 200 ml bottles that we have. And what the studies show us is that when you use fish oil containing enteral nutrition, especially in respiratory distress patients, it reduces the length of ventilation. It reduces the length of ICU stay. Sometimes there's a question on mortality, but overall, fish oil has been shown to reduce the inflammatory index on the body. So we've seen things like CRP and other inflammatory markers or parameters actually being reduced when you do use fish oil enhanced enteral nutrition. You can move on to the next slide. Then also when we're using parenteral nutrition, so somebody commented earlier on TPN, we try to use a lot more SMOF and the reason is that this is enriched with fish oil and it's been clinically shown to reduce infection, length of ICU and hospital stay, and overall, you're improving the patient's inflammatory index. Next slide, please. So when we're looking at these 200 ml bottles, so the nurses may recognize it as the juice bottles or what the patients ask as the milkshake. And, very often the effect of this is underestimated or underrated. This was a study published in 2018. It was a massive study. I think they had more than 100,000 participants. And it was a systematic review, or they looked at, a couple of studies. And what they found was that overall, those little milkshakes or those 200 ml bottles that we see actually resulted in a financial saving of up to 12% on that hospital stay. It was shown to clinically significantly reduce mortality risk. It lowered the morbidity risk by 35%. Your patient had a 35% lower risk of complications, and it was shown to shorten the length of hospital stay by 2 days. And this coming from a simple nutritional supplement in a 200 ml bottle. And this talks to the fact that we assume the patient is eating enough. We assume the patient is meeting their requirements, yet we don't know precisely what is their requirements. And we know that in the hospital setting, patients have the diets that are planned for general public, about 70 kg patient. That's the sort of menu that will meet their RDA. What happens when we're dealing with a 100 kg patient who's had 2 massive traumas and they're catabolic as ever? And this is where the oral nutrition supplements come in. If you can move on to the next slide. Next slide, please. I hope I haven't put you guys off to sleep as yet.
No, you didn't. It's just I'm going to show
Okay.
and again, just give me a sec. We're definitely challenged today.
We've been
Doesn't
nearing
wanna
the end. So
Okay, sorry.
is there a way for me to change it?
No, unless we give you a presentation right, but no.
Okay, if you just,
Oh, here we go.
oh, there we go. Okay. Okay, so this was the study that we were talking about. Actually, it wasn't 100,000, it was 724,000 patients. So again, close to 1 million patients. And what they basically showed was every $1 that was spent on oral nutrition supplements resulted in a $52 saving in hospital costs. So, you know, if I was a funder or I was a patient even, I wouldn't mind, you know, spending, or if I'm more of a funder or a hospital, I wouldn't mind spending that $1 to save 52 in the hospital cost. And ICU survivors need at least 3 months of high protein oral nutrition supplements. But in the South African context, we know that, you know, resources are quite scarce. We know funders are quite sticky in terms of what they will approve. But what we as dietitians are doing is we increasing motivations for these patients that are out of hospital to say, can we get 3 months of nutritional supplements? We're monitoring their muscle mass to show the impact of the nutritional supplements. And it's not always favorable from the medical schemes where they do approve it, but we just trying to flood them with the motivations and flood them with the data to show them that when we allow this intervention of a simple 200 ml bottle twice or 3 times a day, you are improving this patient's outcome. And we could move to the next slide.
I would love to. Hold on. No, here you go. There you go.
Oh, is that the next slide? Sorry. Okay,
Yeah.
they all look the same to me. So from the study also, what they found was there's a generalized underutilization of oral nutrition supplements. This was another study actually that was done in 2019. And what they found was that in their study, they had only 5% of their patients were classified as malnourished. And if you look at globally, it's about 50 to 60% that are in that malnutrition category. So obviously they highlighted, even the authors said, they highlighted the fact that there's probably a lack of systems to diagnose or pick up these malnourished patients. And also that of the 8,000 people that they classified as malnourished, a remarkable only 3% of them received oral nutrition supplements. Such a simple intervention, but hugely underutilized. We know that ONS was also found from the study to be associated with nearly 40% fewer 30-day readmission. So it takes us back to the first thing I spoke about when I started this talk. Let's start moving away from nutrition as something for sustenance, but rather for something that can affect important things like mortality, readmission, infection rate, complication, and so on. What the author did conclude was timeous ONS and a shorter interval between starting it actually resulted in a shorter length of stay. Could go to the next slide. Now you can go to the next one as well. I think we're ending up now. So the way forward is obviously early nutritional intervention, implementation of screening tools, and that's where us as dietitians come in. But also, you know, whether you're a nurse or whether you are a specialist or whether you are an EMS person, the more people we have just having that awareness of how's their nutritional status. If you're an EMS person and you're picking up a trauma, you know, when you're looking at that patient, even if you just do a small mention of a fall that, sure, very low muscle mass, this one's going to need some supplements soon. That can actually change or help to improve the time before supplements are started. And remember, we're saying the interval between starting the supplement and admission impacts the length of hospital stay. Also then minimizing delays in starting feeds, as I've said, minimizing unnecessary stopping of feeds, and that's through protocols and through training of staff, better communication with all departments. We do fluid and feed charts in the file we do each day, where we try to track what we had prescribed versus what was actually delivered. The research says it's normally between 50 and 70%, where if a dietitian prescribes 1,000 kilocalories for that patient, most times what's delivered is around about the 500 to 700. So this is due to various stops in treatment because of procedures, maybe the feed has run out and various other things, you know, things that can be addressed quite efficiently. So we know in the recovery phase, the patient needs a lot. And we've got to work really hard to be mindful to say, even if you're a nurse, that if the feed is off for so many hours, maybe chat to the dietitian. Is there a way that we can catch up on the feeding? Because that patient's nutrition is going to impact how he does in the end of that admission. And just lastly, an MDT approach is very important to treating the nutritional status of the patients. Thank you. I hope I didn't make everybody fall off to sleep.
Thank you so much, Omin. I know I pressurized you for the time, and thank you so much for being accommodating, and it was an excellent talk. Is there
Okay,
any
sure.
comments from anybody? Irene says it's such an important topic and crucial to holistic care and better prognosis. So thank you, Irene.
Very
Is there
informative.
anybody else that wants to comment or questions? So we're going to try again. I hope Mandy has the magic touch like she normally does, and we're going to try again the ASH presentation. If it's not successful, I will actually send it to you, the link, and you can listen to it, but let's solve thumbs and hope it's working.
Thank you, Marisa. Just give me 2 minutes to share my screen. Can you see my screen, Marisa?
Not yet, Mandy. Yes.
So you can see it now, hey?
Can, yeah.
Okay, let's try and see. I just want to make it big. Just tell me what goes down.
It is playing, it's just not yet.
Introduction. The role of the
Yes, it's working.
physiotherapist
Thank
in ICU for trauma patients. Physiotherapy is an essential component in the management of patients that are admitted to ICU. Traditionally, the role was limited to respiratory care. However, over the last decade, rehabilitation and mobilization have become priority. Studies have found that patients undergo deconditioning of both the skeletal muscle as well as respiratory muscles, which collectively, once ventilated, increase mortality and morbidity. The ultimate role of the physiotherapist in ICU is to apply advanced, cost-effective therapeutic modalities to decrease the patient's dependability on a ventilator, to improve residual function, to prevent the need for new hospitalizations, and to improve the patient's quality of life. So what is quality of life? Quality of life, which is defined by the World Health Organization, is an individual's perception of their position in life in the context of the culture and value systems in which they live, and in relation to their goals, expectations, standards, and concerns. The European Respiratory Society and Intensive Care Medicine Task Force are in the development of evidence-based clinical management algorithms for the prevention, identification, and management of pulmonary dysfunction in intubated patients in ICU, and for the early physical activity and mobilization of critically ill patients. Many ICU patients have an unmet potential for physical therapy and are subjected to unnecessary immobilization. The notion that the patient is too sick to get out of bed is being replaced by the notion that the patient may be too sick to afford staying in bed. To understand the role of the physiotherapist more comprehensively, we will discuss the following areas: assessment of the patient in ICU that is relevant to trauma, and outcome measures that is used to develop guidelines and protocols. We will also look at some functional impairments and treatment plans used by the physiotherapist to perform their roles. Finally, we will discuss the role of the physiotherapist in the multidisciplinary team. Assessment of the polytrauma patient. There are three major categories. 1. History taking. General information regarding the nature of incident, mechanism of injury. This information is usually passed over from the paramedics to the trauma surgeon, which is of vital importance. 2. Systems review. These patients will require a more detailed investigation and radiological intervention due to multiple systems that may be impaired. Stepwise approach will require reviewing the doctor's assessment of the A, B, C, D, E, F, G. A being airways, breathing, circulation, disability, electrolytes, fluids, and gastro and abdominal examination. A polytrauma CT scan is performed based on the findings that include a CT of the brain, neck, chest, abdomen, and pelvis. In patients with potential vascular damage, a CT angiogram may be required. Once a patient is in ICU and stabilized, the physiotherapist does a systems review of the following areas. Number 1, the respiratory system. Assessment of the respiratory system. Ventilator settings. We look at the mode of ventilation, we look at the PEEP, the breath rate, FiO2, peak pressure, the respiratory rate. Then we move on to the vital signs. We check for the saturation of oxygen. We look for the respiratory rate. We move on to the X-rays, the CT of the chest. Here we look for lung collapse, if there's any chest infection, rib fractures. Pneumothorax is common in stab wounds, MVA, and gunshot wounds. We look at for fractures of the thoracic spine. Auscultation, determine the air entry and buildup of secretions and breathing patterns. Cough, can the patient cough? Can we collect any sputum? Does the patient have any respiratory muscle function? Is the patient completely sedated and will require us to have clearance secretion techniques to loosen up and remove any secretion in the lungs? Then we look at the ABGs. This is important because sometimes with trauma patients, you'll end up having a patient that will undergo respiratory acidosis, which can be found in patients with traumatic brain injury due to central nervous system depression, chest trauma, and this will present with patient with increased respiratory distress, confusion, cognitive dysfunction, which will influence the treatment plan of the physiotherapist. Outcome measures used. The MRC breathlessness scale ranges from grade 1, which is not troubled by breathlessness except for strenuous activity, to grade 5, shortness of breath during the minimum movement like undressing. Respiratory muscle strength, we determine the MIP of the patient, which is the maximum inspiratory pressure. Assessment of the neurological systems. Assessment of the neurological system include various factors such as level of consciousness, generally measured by using the Glasgow Coma Scale, the reactivity of pupils, reflexes, muscle tone, intracranial pressure, and the review of the CT brain and MRI scan. Trauma patients commonly are admitted with traumatic brain injury, either mild or severe. They have fluctuating GCS levels, cerebral edema, CSF leak, hypoxia, brain tissue damage, and high intracranial pressure. All of this can result in severe long-term neurological impairments or even death. The CT brain and spine is extremely important to determine if the patient has any base of skull, facial, or even spinal fractures, edema, and brain injuries. The MRI scan is helpful in determining if the patient has any spinal cord damage, if there's any disc prolapse, which may affect the neuromuscular function and even lead to complete loss of motor and neurological sensation, and sometimes even urinary incontinence. So the assessment tools that we use to measure outcome measures will be the RAS scale, which is a Richmond sedation scale, and the Rancho Los Amigos levels of cognitive functioning. Three, cardiovascular systems. Assessment of the cardiovascular system and circulation system is often assessed concurrently with the respiratory system. Here we look at the patient's vitals, which is the blood pressure, ECG, heart rate, perceived level of exertion at rest with or without activity. We look at the patient's bloods. Cardiac enzymes are used to determine if the patient has any abnormal functioning of the heart. This is normally associated with patients that have blunt chest trauma and chest contusion. Outcome measures used. We use the Bog scale. We use the age predicted maximum heart rate, HR max. So generally that is 220 minus your age. Example, a 50-year-old male will have an HR max of 170. So in order to initiate mobilization, it's more safer to be 50% of your maximum heart rate. Exercise intensity for acute to subacute patients generally range between 40 to 70% of the maximum heart rate. Four, musculoskeletal system. This component is the most common amongst trauma patients, as majority of patients sustain physical and mobility dysfunction with associated soft tissue injury and or fractures. We review the X-rays and CT scan to determine any fractures and or organ damage. ABGs are done to determine the lactate levels, which is a byproduct of anaerobic metabolism, an indication of cellular degeneration and tissue hypoxia, normally between 0.3 and 0.8. Anything greater than 2 over a 24-hour period is a clear indication of severe tissue damage, which is common in trauma patients. Outcome measures. Oxford Grading Scale is generally used as the measure of muscle power. It ranges from grade 0 all the way up to grade 5. We use the MRC sum score. This measures the muscle strength of 3 different movements in the upper body and the lower body. The movements include the shoulder abduction, elbow flexion, wrist extension, hip flexion, knee extension, and ankle dorsiflexion. Muscle strength is scored as per Oxford scale from 0 to 5, and a sum of 60 is determined. A score less than 48 out of 60 indicates ICU acquired muscle weakness. 5. Abdominal and renal system. CT scan abdomen is done to determine any pelvic fractures, blunt trauma associated with any intra-abdominal injuries. If so, an emergency explorative laparotomy is done and repaired. Measurement of fluid balance and urine output is important to determine renal impairment and dehydration, which can cause mucus plugging and in return block the airways. Fluid retention can be a sign of acute kidney injury, which may also be determined later in the trauma patient. Treatment plan and potential impairments. 1. Impaired airway clearance. It's common amongst ventilated patients and patients with chest trauma. The physio aids in clearance of the secretions and weaning them off the ventilator. The modalities used, percussions, very common. You guys hear and see it all the time in ICU. Vibrations, we use that for patients with rib fractures. We're using a vibromat. Postural drainage and positioning. Autogenic drainage uses breathing at different lung volumes to loosen and move secretions. Then we do suctioning via the endotracheal tube. 2. Prevent shortness of breath and respiratory distress. Treatment plan: optimize oxygenation. We use deep breathing exercises, active cycle breathing techniques. 3. Decreased exercise tolerance. Treatment plan: prescribed exercise in ICU. Modalities used: we initiate exercise therapy at the maximum level that each patient can tolerate, that being aerobic activities, which is about 40 to 60% of the age predicted heart rate, or 3 to 4 on a modified Borg scale. Resistance training, 50 to 70% of 1 rep max, 10 reps of 3 sets per muscle group. The frequency and duration can vary depending on the patient's ability to perform these exercises. Once a patient is able to do these exercises, it can be progressed to 2 or 3 sessions per day of no longer than 15 to 30 minutes. The physiotherapist also uses neuromuscular electrical stimulation, or commonly known as EMS. These current help stimulate intramuscular nerve branches as well as help with pain reduction. 4. Decrease mobility and physical function. Treatment plan: first, we have to determine the highest functional level of the patient and initiate early mobilization. The modalities used: so Oxford scale grading. We start with isometric contractions, then move to passive limb movements, active assisted ROM exercises, and active exercises with or without resistance. Functional activity goals: example, mobilizing a patient to the edge of the bed, to standing or sitting on a chair. We focus on the postural and stability muscles, as these muscles generally lose much quicker than the stronger moving muscles. We initiate simple movements like bed rolling and turning. Abdominal bridging exercises helps the patient to strengthen their gluteal muscles, which is a very important component for pressure care, as well as for patients that cannot use the toilet and may need to bridge. Five, decreased respiratory muscle dysfunction. Mechanical ventilation leads to diaphragmatic atrophy. Studies have shown changes in myofiber length and rapid atrophy. Approximately 55% atrophy in human diaphragms following 19 to 56 hours of controlled mechanical ventilation. This was done by a study by Levine et al. In 2008. That's quite a substantial amount of atrophy in the lung, and it's something that we need to look at more seriously. Treatment plan: improve respiratory muscle strength, commonly known as IMT. Modalities: the greatest benefit of IMT in ICU patients were found when using a threshold loading device. Such a device is power breathe and a threshold inspiratory muscle retrainer. Very different from a spirometer, which is used more to improve patients' lung volume rather than muscular strength. So the power breathe device is something new that is used to offer similarly to weight training, but more for your inspiratory muscles, such as your diaphragm. 6. Reduced lung volumes. Treatment plan: improve lung tidal volumes. Modalities: PEP devices for expiration and incentive spirometer for inspiration. This improves volume and not specifically respiratory muscle strength. 7. Improve gaseous exchange. Treatment plan: monitor ABGs in relation to effective respiratory rehab. The aim is to improve respiratory and metabolic acidosis and alkalosis. 8. Improve musculoskeletal function. One of the major complications of bed rest is muscle atrophy. Muscle strength decreased significantly and mass by 1.5 to 2% per day during the first 3 weeks. This was done by a study, Hopkins, in 2009. That is a significant drop in muscle atrophy. If we generally think about it, a normal person going to gym to gain 2 or 3% of lean body mass takes months, if not never. So it's very important to realize that these patients who are immobilized and are lying in bed, especially those that are ventilated, generally lose a lot of muscle tissue. The greatest muscle atrophy was noticed more in the lower limbs and torso. Studies have also shown 73% of patients were unable to walk independently. Modalities used: specific muscle training exercises with detailed reference to the initial injuries, any fractures, or any surgical intervention performed. 9. Neuro impairments. These are common in spinal cord injuries and head injuries. Treatment goals: comprehensive neuro rehab exercises and cognitive stimulation. 10. ICU-acquired weakness. What is ICU-acquired muscle weakness? Well, it's defined by generalized weakness in an ICU patient that is not explained by other reason other than critical illness. So a patient that may come in with an orthopedic condition or a stroke may not necessarily be ICU-acquired muscle weakness, but generally these patients are categorized by patients that are in long-term stay in hospitals and have generally critical illness that cannot be attributed to anything specific. Critical illness such as polyneuropathy, myopathy, or a combination. MRC score of less than 48 out of 60 or less than 4 in Oxford scale across all muscles evaluated. Those are generally the signs we look for ICU-acquired muscle weakness. There's severe protein catabolism, loss in net protein content, and a significant amount of fat-free muscle loss. Reduction in body weight of 1.6 kgs over 2 days in critically ill patients. This was shown in a study by Baldwin et al. In 2012. Severe and rapid loss of fast-twitch muscle fibers with limited capacity of muscles to regenerate due to loss of skeletal muscle membrane excitability. There are studies to show that as well. So that makes rehabilitation even more difficult as the patient loses the ability to regenerate new muscle tissue. Loss of muscle mass has shown to increase mobility and mortality. Mechanical ventilation and length of stay has decreased quality of life and most significantly increased death after 90 days post-discharge. I have a few studies that show this in more detail, and guys are happy to contact me and forward to you guys those detailed studies. Treatment and modality. Early graded mobilization. You start with passives and progress. The only intervention to improve long-term physical function in critically ill patients is exercise and physiotherapy. Also tight glucose and protein control with glutamine and limited use of corticosteroids. And this is where the dietitian comes in play, which helps with this protein and glutamine to preserve the muscle tissue, and in conjunction with the exercises, the patients generally have slightly better chance of maintaining muscle mass and decreasing atrophy. Okay, so this brings me to the final part of my talk, which is the role of the physiotherapist in the multidisciplinary team. The role of the physio is now more integrated in a trauma patient as opposed to a general medical or surgical patient due to the multiple systems and organ impairments that the patient undergoes. The initial understanding of the task at hand, the nature of the injury, and the planning of the holistic care is planned in advance with the trauma surgeon. This is a vital aspect of the initiation of treatment, as a detailed assessment of understanding of the multiple injuries associated with the patient needs to be determined upfront. These patients are at times ventilated on scene or undergo emergency surgery to stabilize the condition by the trauma surgeon. All the necessary referral documents and clinical information required by the medical aids and others is also given by the trauma surgeon. The physio will then engage with the intensivist to manage the respiratory component, especially with ventilated patients that will end up needing to be extubated and respiratory rehabilitation. The physio will then engage with the assigned orthopedic surgeon to discuss the fractures, surgery to be performed, and treatment goals post-surgery. The physio orders any assistive devices or immobilization items such as crutches, walking frame, rhomb brace, thoracolumbar brace. The physio will discuss with the neurosurgeon a comprehensive central nervous system treatment plan and rehabilitation if the patient has any brain or spinal injury. During the daily treatments, the physio works very closely with the dietitian to provide nutritional supply to aid in the recovery of metabolic demands that is placed on these patients. This helps with the strengthening and prevention of muscle atrophy, which is critical for early mobilization and prevention of further impairments, as we have discussed with ICU-acquired muscle weakness. The physio will engage with the occupational therapist to assist with cognitive function assessments and neuromuscular skeletal therapy to improve activities of daily living. Finally, engagement with the psychologist and speech therapist, as the physio spends time with these patients and generally pick up that the patient may have emotional or psychological impairments that will need support from those allied services. All of the above is done in a coordinated manner with regular clinical meetings with the primary trauma surgeon to discuss the progress and prognosis of the patient. Further ICU rehabilitation and outpatient management is continued with the physiotherapist, either in the wards or with the physiotherapist outpatient team. Thank you very much.
Okay, thank you so much, Liash. It was really informative. And this comes to the end of our symposium today. I'm just handing over the mic to Prof. Clark.
Thank you, Mariessa. I'm sure you'll all agree with me that that was a very well-organized, well-run, and enjoyable and informative symposium. We look forward to many more in the future. I'd like to thank all our participants, all of you who've come and all of you who've signed on. I'd like to thank all the people who've put talks together. They were all of a very high standard. And we certainly look forward to hosting more of these symposiums as we go forward. Thank you very much.
Thank you very much.
Thank you, everybody. I'm going to end the recording and the meeting now, unless there's anything anyone wants to put on.
Thanks, guys. Thank you.